Good morning, and welcome to the Cancer Survivorship Summit. Please welcome to the stage Congresswoman Debbie Wasserman Schultz, Senator Dr. Barbara Sharif, and NSU Chief Medical Officer Dr. Chad Perlin.
Good morning. This is so wonderful seeing everyone here today. Thank you for being here. I'm Dr. Chad Perlin, the Chief Medical Officer of Nova Southeastern University, and I also have the privilege of serving as Dean of our College of Allopathic Medicine, the MD School. And it is truly, truly a great honor to welcome you all today to Nova Southeastern University and to this year's Cancer Survivorship Summit. Today is about hope, it's about resilience, and most importantly, it's about progress. It's about celebrating survivors, supporting families, and advancing the science and the care that will make survivorship not just possible, but expected. At NSU, we believe deeply in the power of research, education, and collaboration. NSU faculty, students, researchers are working together every day to foster breakthroughs in cancer prevention, treatment, and overall care, and recovery, and survivorship. We know we cannot do this work alone. That is why gatherings like this are so important. They bring together our survivors, our clinicians, our researchers, our scientists, our advocates, and our leaders with one purpose. One of those leaders is here with us today, and before we begin, please welcome Senator Barbara Sharif. Senator Sharif is an autonomous nurse practitioner and a trailblazing public servant who made history as Broward County's first female African-American mayor. Now, as state senator representing District 35, she brings decades of healthcare leadership, expertise, and tireless advocacy for our community. Senator?
Thank you, and good morning. It is truly an honor to be here at this Cancer Survivorship Summit hosted by our great Congresswoman Debbie Wasserman Schultz. She does a fantastic job at everything that she did for us and for the County of Broward, and we really appreciate her. As your state senator for District 35, I am also a doctor of nursing practice with more than 30 years of experience caring for patients and families in our community. That dual perspective, both in healthcare and in public service, gives me a unique responsibility. I have seen firsthand the courage of patients and families navigating a cancer diagnosis. And I know how critical it is that their care does not stop when treatment ends. Survivors remain among the most vulnerable in our healthcare system, and their voices must guide the policies we create. Today, more than 18 million people in the United States are cancer survivors. By 2040, that number will rise to 26 million. Behind those numbers are individuals, families, and caregivers, each with a journey that is deeply personal. That is why this summit is so important. Together, we are shining a light on the gaps in survivorship care, exploring innovative policy solutions, and strengthening the support systems that survivors need to live not only stronger, but longer. From keynote addresses and fireside chats to panels, workshops, and community resource fairs, this event is about action, connection, and hope. It brings together health professionals, advocates, survivors, caregivers, and policymakers to build bridges and create solutions that last. As your senator and as a lifelong nurse practitioner, I'm committed to making sure the lessons we learn here today help to shape a future where survivorship is fully supported, where every person has access to the care and resources and community that they need to thrive. Thank you, and thanks once again to our wonderful Congresswoman, Debbie Wasserman Schultz.
Thank you, Senator. And we are especially fortunate today to be joined by someone who has long been a champion in the fight against cancer. Someone whose vision and tenacity made today a reality, bringing this summit not just to NSU, but to our community and across South Florida. Congresswoman Debbie Wasserman Schultz has dedicated her career to public service and to advancing healthcare policy. She has used her personal journey to drive national awareness, expanding funding for cancer research, and efforts to promote care, early detection, prevention efforts, and survivorship. Congresswoman, we thank you. Her leadership in Washington and in our local community has given a voice to survivors, families, and she continues to be a powerful advocate for innovation, equity, and access in healthcare. Please join me in giving a warm welcome to Congresswoman Debbie Wasserman Schultz.
Do a little rearranging back here. I'm a stagehand as well. Thank you so much, Dr. Perlin. Thank you for that really kind introduction, and thank you so much to Nova Southeastern University for being the most remarkable hosts, for being the premier institution and one of the crown jewels of Florida's 25th Congressional District. I appreciate your welcome and the incredible work that your team does every single day. And thank you so much to my dear friend, Senator Dr. Barbara Sharif, who is a fierce, incredible leader who has really blazed a remarkable trail throughout her career. We have spent many years together fighting side by side, particularly when it comes to access to quality, affordable health care, and I can't thank her enough for joining us this morning. So good morning, everyone. What an incredible turnout. I'm so thrilled to see everyone here. The turnout this morning on a Saturday morning demonstrates how vital it is that we be able to come together around this important issue of survivorship. It is my absolute pleasure to welcome you to our second Cancer Survivorship Summit right here at Nova Southeastern University. Go Sharks! At our first summit, I said that I hoped that NSU would become the permanent home of this event, and here we are back again, and hopefully for many years to come. This gathering wouldn't be possible at all without so many people. So indulge me as I thank some key people without whom this event would never have been able to occur. First to NSU, President Moon and your entire NSU health team, thank you so much for opening your doors. Your hospitality and your patience are boundless and so deeply appreciated. And thank you again to Dr. Chad Perlin for the wonderful welcome, kind words, and for such tremendous leadership at the medical school here at NSU. We are one of the few universities here that have both an allopathic and an osteopathic medical school, and that has really enabled us to make sure that we are a central address when it comes to medical education here in South Florida, but across the United States and even the world. And having spent a dozen years of my life as an employee here many, many years ago, it makes me additionally proud. And this is the only university whose main campus is in my congressional district, even though I have branch campuses of many others in this incredible education center here in Davie, but I'm very proud. So it's just, I'm so thankful. I also want to give a special shout out to Ricardo Belmar, Maria Lemmy, Kyle Fisher, her public relations and marketing team, and Gustavo Padrino, Ayana Vale, and all the wonderful people here at the Miniachi Performing Arts Center. You should know that this event is only possible today because of their incredible work. So please join me in giving them a round of applause. Thank you. I want to thank my dedicated staff for the incredible work that they did in helping me put this event together, especially Patrick Kotzel, my senior policy advisor, who helped me bring my dream of a Cancer Survivorship Summit to life and grow it to this event that we are here at today. And to all of our speakers, workshop leaders, community partners, and the many organizations staffing tables at our resource fair or staffing the mobile units, your presence here today is so vital. Survivorship is not a solo journey. It takes a network, as anyone who's survived cancer knows. And you all are that network. So thank you for graciously devoting your time to this cause and to my vision. And one other guest who I must thank personally is our very special keynote speaker, Bill Zito. Many of you know him as the president and general manager of our beloved back-to-back NHL Stanley Cup champs, the Florida Panthers. But what many of you may not know is Bill is an integral voice and a true warrior in our fight against cancer, and I'll share more on that shortly. We're so fortunate to have Bill here today as our keynote speaker, and to our audience and participants, for those who traveled and fought through our infamous South Florida traffic to be here, or those of us joining us online, thank you so much. Yeah, I heard the traffic chuckles because we all know you are all why we do this work. Now, I want to ask everyone here something personal, and please only answer if you feel comfortable, but raise your hand if you are a cancer survivor yourself. Yes. The sister and brotherhood is real. How many have a close relative or friend who is a survivor? Amazing, amazing. And how many have been caregivers, professionally or just simply for someone you love? I just want to note that nearly every single person in the audience raised their hand because cancer touches all of us. Today, there are more than 18 million cancer survivors in the United States, as you heard from Dr. Sharif, and by 2040, that number will likely reach 26 million. Now, we'd rather have survivors than mortality, but every year, 2 million more people are diagnosed with cancer. Thanks to advances in research, treatment, technology, and early detection, more of us are living longer, fuller lives after hearing those dreaded words, "You have cancer." For survivor, the moment you hear those words, everything changes. Your world literally turns upside down. Questions flood your mind. Am I going to die? Can I keep my job? How will my family cope? How will I pay for this? You are consumed by frantic thoughts of mortality. Appointments, medications, side effects, they all start to dictate and eventually control your life on a daily basis. Routines that once seemed ordinary, taking your kids to school, seeing friends, enjoying hobbies, suddenly feel both impossible and precious. And even if it's not you, but someone you love, those words change your life forever. That moment will dictate so much of the rest of your life and, of course, your family's lives. Hearing those words, you forget where you're going or what you're supposed to do. I know because I heard them. And after that, everything is harder, more of an obstacle that you feel like you can't see over. Managing your life becomes so overwhelming. Some worry how they will pay for their care. How will you be able to help your family moving forward? What should you share with your children and when? Or do you want to share your diagnosis at all with anyone other than only those who need to know? Life is so very different when you've been diagnosed with cancer, or when you are caring for someone who has cancer, or if someone you love is battling cancer. Even if it's not you, but a loved one or close friend who heard those dreaded words, we have all been there. 17 years ago, I heard those 3 words myself: you have breast cancer. I was also hit with a second punch when a genetic test determined that I carried the BRCA2 gene mutation, which as an Ashkenazi Jewish woman, a Jewish woman of Eastern European descent, I had a much higher likelihood of carrying, and I didn't even know that. That meant I was 5 times more likely to develop breast cancer and had up to an 85% chance of ovarian cancer before age 50. I fought through 15 months of surgeries and treatment privately, sharing the news only with those I needed to know. Thankfully, I remain cancer-free today. But that experience changed me. I emerged fiercely determined even more to use my voice, my vote, and strength to help eradicate this terrible disease, and it gave me a personal mission. As a legislator, I knew I could use my platform to help others survive, to make sure that women caught cancer early, and to fight for access to care. That mission has guided much of my career in public service. Healthcare policy and keeping people safe, healthy, and protected are the foundation of why I serve. And it's been one area where I'm thankful to have made real policy impacts, particularly with cancer. I never want anyone to hear those words that I did over 17 years ago, but if they do, I want us to be able to be there for them during and after their diagnosis and treatment. And we want them to be able to catch it early, increasing their chance for survival. Throughout my entire professional career, I've advocated for education, early detection, prevention, and survivorship. My top policy priorities strive to enhance and protect access to early screenings. It's clearly one of the best tools that we have to beat this disease. I fought relentlessly to pass a law, the EARLY Act, that created a national education and awareness campaign that raises awareness about breast cancer risks that younger women face. It also targets awareness efforts to women at higher risk and funds an education campaign for providers to share the unique ways that breast cancer manifests in younger women. Because too often, even healthcare providers are not aware that young women can and do get breast cancer, and that when we get breast cancer, it often manifests and shows in different ways. Too often, we have gaps in our ability to make sure that we can even be diagnosed. This law also provides grants for groups to help with this mission, and some of these great organizations are with us here today. The funding assists young women dealing with the unique challenges that we face when battling breast cancer. I also passed a law that guarantees women's access to annual mammograms starting at age 40. The fact that we had to make that a law is a story for another day, but the fight continues, and so does the law, to ensure that we have access to health care when it is scientifically documented that that is essential. And I recently created a program with $10 million in annual funding to increase access to cancer screenings and treatment referrals in underserved communities, because access to screenings and care, thank you so much, access to screenings and care saves lives, and your address and your socioeconomic status should not be a barrier to that access. But the work we do doesn't end at diagnosis. Survivorship itself needs more attention. That's why I'm fighting to pass an ambitious piece of legislation, my Comprehensive Cancer Survivorship Act. Thank you. This legislation takes on the entire survivorship journey, from diagnosis to treatment to hopefully your natural end of life. Too many survivors, and that's why we're here today, feel lost in the transition. They finish treatment and then suddenly the support system fades. That's unacceptable. Survivorship is lifelong, and it is a journey. And we cannot just throw people at the end of their active treatment into the wilderness to face the Wild West and figure out what pathway is the right one for them, or assume that once you're done with active treatment, everything's good and you don't need to worry about anything anymore, or assume that people don't worry about anything anymore. I am confident that I will continue to be a survivor, but I think about my breast cancer and have physical manifestations of it every single day. And every survivor here, I am sure, is in the same boat. So, survivorship is about empowering patients to make choices, helping families navigate the unknown, and assuring no one's situation is ignored. There is no single right way to navigate survivorship, but whatever your path, you should never do it alone. I've collaborated with so many of you in this room on this bill, and so I thank you again for all your tireless support for our mission. This survivorship journey is about having comprehensive support throughout our lives so we can survive and thrive. And my hope is that we can make this legislation the law of the land and build upon its foundation for generations to come. And that brings us here, to this summit. It's one more tool in our arsenal to help survivors, a gathering of expertise, resources, information, answers, and a call to action. Because really, how many of us have time in our lives to run around and try to find all these resources individually on our own, one at a time? So making sure we have, at least annually, a one-stop shop for cancer survivorship and our families and caregivers and all the people that are trying to help make sure that we grow more survivors while we're still battling the beast that is cancer is essential. Today is about shining a light on the survivorship journey, supporting survivors, families, caregivers, and providers. It's about making sure survivors don't feel lost or forgotten, and that they leave here with hope, tools, and community. We have speakers, workshops, a resource fair, and mobile units, all to provide knowledge, services, and support. And I encourage you to take part in every aspect of what today has to offer. At our core, we're all here because we share the same mission, to eradicate cancer as we know it. And we have all come together today to conquer some part of that unified mission. A cancer diagnosis manifests very personally, and each of us experiences it differently. And my wish is that everyone finds some useful part of what you need today during our shared mission, and afterward we'll all feel a little less lost as we climb that daunting mountain. So here's what to expect today. You'll be exposed to a lot of important information. We'll have many experts on this stage, experts that are some of the brightest minds in cancer care, coordination, and advocacy, and they'll discuss many topics in presentations, panels, and a fireside chat. In the afternoon, we'll have some interactive workshops covering financial toxicity, survivorship connections, and health and wellness. Thank you to Blood Cancer United, Gilda's Club South Florida, and Baptist Health for leading these important workshops. They're a great opportunity for you to get a more interactive and personalized learning experience. And we also have a resource fair and mobile units offering their services. So thank you again to the many, many organizations and providers for devoting their time and their services to our community. My office also has a table out there if you have any questions or need to discuss any constituent assistance with a federal agency. And don't hesitate to stop by and say hi to my team, even if you just want to put yourself on our contact list so you can receive updates from us when they are relevant. And I especially encourage you to keep in touch with me and my remarkable team over time. Lastly, I'll close with this. Cancer is not and should never be a partisan issue. Cancer certainly doesn't care what party you belong to, but I'll make this one point. A dramatic effort is underway to erase and erode a lot of the progress that we are making in our fight against cancer, a fight that has helped prevent cancer from disrupting and ending more lives. And I knew I'd break at some point. And so long as those rollbacks continue, the cancer risks that we all confront will not disappear, but in fact grow. Survivorship must give us a chance to come together across political differences, united by a shared mission. We each have a role to play, including fighting against those rollbacks and those cuts. We have a lot of work ahead of us. But standing here today, looking out at all of you, I know we are united as a family, friends, and a community to press forward and continue to make progress. You are in my corner, and I promise I will always be in yours. Thank you for being here today.
Good morning, everyone. I'm so honored to be here today to speak about early detection, and I think I had a few slides just to help me keep going as I talk. I want to thank the Congresswoman and her staff for bringing me here to talk a little bit about this topic today. If you could go to the next slide. I'm here today on behalf of the American Cancer Society. For those, I'm so lucky. For those people that don't know about the American Cancer Society, this is an organization that has existed since 1913 to raise awareness about cancer within our society. And early detection has been part of that mission for the entirety of the time the organization has existed, and is part of the American Cancer Society's vision of ending cancer as we know it for everyone. If you could go to the next slide. I just wanted to start a little bit today by defining early detection for people. We talk a lot about screening for cancer, and screening is really designed to identify cancer before a patient has symptoms, at a time where treatment is potentially easier on the patient and more likely to be successful. But also, early detection sometimes happens in an asymptomatic patient incidentally because they're having a workup for some other condition. Also, early detection can happen because of the onset of symptoms, and a patient recognizes those symptoms and receives quality health care, at which time a cancer diagnosis is made. And of course, the goal of early detection is to improve cancer outcomes at the end, and a lot of this is driven by cancer biology, which is outside of all of our control. The next slide. So there are today 5 different cancer disease sites where early detection and screening has been demonstrated scientifically to improve cancer mortality, improve cancer outcomes through a decrease in cancer mortality. And you can see those are breast, cervical, colorectal, lung and prostate cancer. And as you can see from the far side of this slide, the prevalence of Americans that are up to date with these screenings falls short of all of our public health goals, and varies widely from lung cancer being in the low teens to breast and cervical cancer being higher, but not quite where we need to be. If you could go to the next slide. And even despite us having these screening tests, many cancers are still diagnosed at a late stage. Over half of cervical, colorectal, and lung cancers are still diagnosed when they are metastatic or spread. And this incidence varies greatly by state, as you can see from the map here. And this is partly because screening rates vary by state and geography, but there are also multiple other local and community factors that impact and influence the diagnosis of cancer. And if you could go to the next slide. There are many barriers which I think all of us in the cancer community are familiar with, which limit access to screening. These vary from things like patient distrust of the medical system or fear, to things like insurance coverage, cost, and transportation that we can all work on together but require structural changes. And the next slide. What I really wanted to talk about today and mention is the barriers to early detection that come after screening. We all know that screening is really a process. It doesn't end with the test. Even after a test is performed, the results have to be received by a patient. And that sounds very straightforward, but for many people, especially those people on the wrong side of the digital divide, this is not always easy. After results are received, a patient needs to be referred for a diagnosis, needs to receive those results, and they face barriers along the way of transportation, access to care, cost, which may ultimately influence the outcome of improving cancer mortality or reducing the amount of treatment that's needed. And even when a patient does get to a cancer diagnosis, there are still barriers that come in the way. And we know that there are large numbers of patients today in America who avoid or delay care even after they are diagnosed with cancer because of some of these issues with transportation and cost. The next slide. And so there are a lot of numbers on this slide, and I promise I'm not going to talk about all of them, but I just wanted to say that overall, it's about half of patients who have an abnormal screening test in this country across disease sites who do not receive a diagnostic test. And so we know that if screening is a program, that doing the screening test is not enough. We need to ensure that patients are making their way all the way to a diagnosis and all the way through their access to treatment so that they can become survivors. And this is just incredibly important today to think about. The next slide. Also, one thing that we're all very concerned with is the rising incidence of cancers amongst young people. And because screening requires certain population prevalence to be effective, for these folks, screening may not be the best way to identify cancers early. And I think we all, in the face of these numbers, really need to think about new ways of detecting cancer early and thinking about screening and prevention of cancer. The next slide. And so it's also important, and especially important for these younger patients who are facing a cancer diagnosis, that we think about symptom prevention in our communities. There are many cancer symptoms which oftentimes are vague. However, patients are often dismissed, especially these younger patients, when they present to their healthcare provider to report things like fatigue or bloating. And I think this is important. Even once a patient reports symptoms to the healthcare system, they may be dismissed, they may have financial barriers that limit their access to care, and this also prevents the success of early detection. The next slide. There also are upcoming innovations in technology, which is promising to really change the who, what, why, how, and when of cancer screening. Blood tests for cancer detection are improving in accuracy every single day, I think. Many of these cancer screenings and other diagnostics can now be done at home, and artificial intelligence is changing the way that we model and think about risk categories, which all is important to consider as we think about the future of early detection. The next slide, and of course I would be remiss if in my last few minutes here on this tiny 10-minute presentation if I didn't mention the importance of cancer prevention. This is the best case scenario that better than early detection is that we prevent cancer before it even happens. We know that almost half of cancer deaths are related to modifiable factors. There's things that we can do in terms of tobacco cessation, diet, exercise, and we do have a vaccine to prevent cancer that has been FDA approved since 2006. The next slide. And so I just wanted to mention in my very last minute a couple of things that the American Cancer Society does to help promote early detection. In 2025, we launched a new web-based application called Cancer Risk 360, which provides a personalized risk assessment and actionable items that an individual at average risk for cancer can take to prevent cancer. And there's a link in that tool to the American Cancer Society screening locator tool. So you can find places to get a mammogram or colorectal cancer screening that's in your neighborhood or close to your home. The next slide. And also as part of the American Cancer Society's activities, we're working to educate healthcare professionals on the importance of early detection. We have several upcoming programs coming through our ECHO program this fall, including a session on multi-cancer detection tests. The next slide. And also we have been recruiting primary care clinicians to a primary care clinician corps whose mission it is to improve cancer screening and early detection within their local communities. And so if you know anybody who's interested in joining this program, we're happy to have them. And I think that's it. And if there's a minute, I'm happy to take a question.
If there are any questions, feel free.
Yeah, I see your raised hand in the middle there. So the HPV vaccine HPV is the primary cause of cervical cancer, but is also causative in several other different cancer types, including vulvar, vaginal, rectal cancers, and many head and neck cancers. Yeah. Oh.
This may not be a question for you, maybe for the group. Who is working to expand what Medicare covers as far as these procedures and things like that? Because I'm in a fight with them right now over cold cap, and the Congresswoman her office has helped. But who's actually working to make sure Medicare expands the things that they cover in these kinds of treatments? Thank you.
I'm going to say I think that's where you're very lucky to have the Congresswoman who's working on these issues. The American Cancer Society also does have a legislative arm, an advocacy arm, which I believe there's somebody here today who you can talk with as well.
Hi. I'm the person here with ACS CAN. Hi, Dr. Tunkin. We're at the resource fair, so we have a table right there, right next to the table. So come by and we can talk about it. But we are actually working on it, including the Medicare Multi-Cancer Early Detection Screening Act, which would make sure that all these new tests are covered by Medicare. At the resource fair, ACS CAN, the American Cancer Society Cancer Action Network. We are the advocacy arm of the American Cancer Society.
Right back there, hold on. Keep your hands up. Sorry. Oh, great. Thank you very much for all this information. I'm not sure also if this question is for you. But most recently, I'm noticing that for pap smears, they're indicating that people as young as 35, 37, they don't need to do one for every 3 years. So now they're deciding that their insurance companies are saying every 3 years. I just had a niece who said, I don't have to go back for 3 years because my insurance won't pay for it. So we need to find out, we're doing a lot of work on your side, every other side, and we have those barriers where who's paying for it, how is it going to work? And it's getting a lot. I can't believe in the 30s that they're saying that number. Her mom died from cervical cancer because she's very anxious. She's like, no, we're not paying for that. So I just want to bring that question out there. It might not be your question, but we have a lot of other work to do. While you're doing good work, everybody else is, then the insurance companies are doing their own thing.
So I will just say that the cervical cancer screenings have changed a number of times over the last 2 decades, and most recent recommendations are for primary HPV testing, which, depending on a clinical situation, can be done at 1, 3, or 5-year intervals.
And this will be our last question.
Yes, I had a question. How often do you go out and ensure that the veterans who have a lot of cancer because of toxic exposure gets assistance from the American Cancer Association? And how closely do you work with the Department of Veterans Affairs to ensure that we can get help?
So I'm not sure I can answer that exact question, but the American Cancer Society is here to end cancer as we know it, for everyone, and so you're most certainly included. There also is a lot of information on our website that may be of interest to you, and I will maybe try to talk to you a little bit about whatever your specific needs are afterwards. Thank you so much.
We are simply applying what we know works. Navigating women through affordable and accessible care. And building a system where no woman is left behind. Thanks to the leadership of Congresswoman Debbie Wasserman Schultz, we've been friends for a long time, and the Promise Fund and Broward Community and Family Health are proud to open a new Promise Fund Women's Health Program right here in Broward County. The Promise Fund is a real game changer, and with partners like these, we are just getting started.
As a cancer survivor myself, I know how critical it is not only to detect cancer early, but to ensure that women can survive and thrive after treatment. That's why I fought to bring federal funding here, to make sure more women have access to the care they need and deserve. This center isn't just about screenings and treatment, it's about survivorship, access, and hope. I'm proud to stand with my dear friend Nancy Brinker, the Promise Fund, and Rosalind Frazier, and her team at Broward Community and Family Health Centers to make this possible.
It's just an image coming true. It really is.
Broward Community and Family Health Centers is honored to be a partner with the Promise Fund and Congresswoman Wasserman Schultz to bring this program to life. The site is more than just a clinic. It is a lifeline for women and families across Broward County. State-of-the-art mammography and ultrasound equipment, and with navigators guiding every step, we are giving women the chance at survival. Thank you for entrusting us with this mission. We are proud to serve.
Join us. Together, we can change the system, save lives, and keep the promise.
Please welcome a special guest, Lainey Jones, the early detective who will share her survivorship story.
Thank you so much. Good afternoon, everyone. Imagine hearing the words, "You have cancer," once. Now imagine hearing it 7 times. For many, that reality would feel unbearable. But for me, each diagnosis became a call to rise above, to fight harder, to live every day with an unwavering spirit. My name is Lainey Jones, and I stand before you today not only as just a survivor, but as a thriver. I'm a testament to resilience, hope, and the life-saving impact of early detection. My journey began at just 18 months old when I was diagnosed with adrenal cortical carcinoma. Though I was too young to remember that battle, the echoes of cancer would shadow my childhood. Then in 2008, at the age of 24, my world was shaken again with a diagnosis of stage 2 breast cancer. I remember sitting in my doctor's office. My heart was racing, fear was wrapping around me as I wondered what was next. After a double mastectomy, I felt lost and uncertain. Then a volunteer from the American Cancer Society's Reach Recovery Program contacted me. She was a 60-year-old breast cancer survivor, and she offered me a glimpse of hope. She became my guiding light, and her words echoed throughout in my mind. Never give up. Stay positive and keep going. As cancer continued to invade my life, those words played time and time again. I faced melanoma in 2009, and thyroid cancer in 2010. I received my 4th primary cancer diagnosis and learned I had a genetic predisposition called Li-Fraumeni syndrome, a rare genetic condition predisposing me to multiple cancers. I had felt as if the ground had shifted beneath me. It was overwhelming, but instead of succumbing to anger or fear, I chose gratitude. Understanding my condition empowered my medical team at MD Anderson and me to stay ahead of the disease. catching cancer early, time and time again. Early detection became my mantra and my key to survivorship. Though I experienced multiple reoccurrences, each was caught early and became a subchapter of my greater story. Then on Halloween of 2023, life threw one of its hardest challenges my way. After a seizure and a quick turnaround CT scan from Lynn Cancer Institute showed spots on my brain. After a craniotomy to remove those spots, it revealed I have glioblastoma. A form of brain cancer. This was right before my 40th birthday. It felt like the universe was testing my strength again, but with each hurdle, I leaned into my resilience and maintained a sense of positivity. During my ongoing treatment for brain cancer, one of my routine scans then revealed my 7th cancer, lung cancer, specifically adenocarcinoma. I never imagined that I'd be fighting 2 cancers at once, but there we were, and here we are. Fortunately, it was once again caught early at stage 1, eradicated with 5 rounds of radiation. And I always remind myself, it could be worse, and there's always someone who has it worse. I feel incredibly lucky that early detection has given me the chance to keep fighting, and that's why I'm standing before you today. I wake up every day with gratitude, celebrating every small victory, a smile from a friend, a sunny day from a simple joy of cup of coffee. My motto is I live every day like it's my first. Each day is a gift, and I refuse to let fear overshadow that. My story is a testament to the impact, once again, of early detection and the power of a positive mindset. It's a reminder that even in our darkest moments, we can find light. I stand before you today not just as a 7-time cancer survivor, but as a thriver who has learned to embrace life in all its complexities. Thank you so much for being here today and allowing me to share my story. I appreciate your time and thank you so much.
I'm right here.
Hello, everyone. I am Marie Woodson, State Representative for House District 105. I am honored to be here today, not only as a representative, but also as a stage 0 breast cancer survivor. My journey and the struggle is a powerful reminder of the importance of screening and early detection and the incredible strength we all possess. When I got the call from Memorial Hospital to be rescreened for something they couldn't find in my breast, and the biopsy revealed stage 0 breast cancer, I felt a whirlwind of emotions. I felt fear, uncertainty, etc. But through the support of my amazing family and friends and the great care that I received from Memorial Hospital, I learned something. Each day is a gift, and we must be proactive in protecting our health. Cancer is often associated with women, but it is crucial to remember that men can be affected too. Awareness and testing are vital to everyone, regardless of gender. I urge all of you to have regular checkups and discussion with your healthcare providers. Early detection can save lives. It's not about surviving cancer. It's about thriving after it. Let's empower each other to get tested. Let's share our stories and advocate for the resources needed in our fight against breast cancer. Thank you for being here today and for your commitment to this cause. My sincere thanks to Congresswoman Debbie Wasserman Schultz for her work in raising awareness on this important issue. Together, we can make a difference. Thank you.
Please welcome Shelley Fold-Nasso, CEO of Cancer Nation, who will moderate a panel called Survivorship Care, Planning and Supporting the Patient's Journey. Joining her are Dr. Frank J. Benedo, Director of the Cancer Survivorship Supportive Care at the University of Miami Sylvester Comprehensive Cancer Center, Dr. Jonathan D. Licht, Director of the University of Florida Health Cancer Center, and Dr. Susan Vadaparampil, Associate Center Director for Community Outreach and Engagement at the Moffitt Cancer Center.
Hello, everyone. I'm Shelley Fold-Nasso, CEO of Cancer Nation. We are a patient advocacy organization based in the Washington, D.C. area, and we work on public policy and advocacy to try to help everyone live well with cancer during and after their diagnosis. I've had the honor of working with Congresswoman Wasserman Schultz for about 17 years. I was there when she announced her breast cancer diagnosis, and I worked with her on the Early Act, and I worked with her incredible staff on the Comprehensive Cancer Survivorship Act, which we are going to work tirelessly with her to try to make sure it gets enacted. Cancer Nation, we changed our name this year from National Coalition for Cancer Survivorship. And Cancer Nation really is about the 18 million people living with cancer in this country and a history of cancer. Because we know that cancer doesn't end when treatment ends, and people live with the effects of cancer for the rest of their lives. And our goal really is to demand a cure for care. Because we know we do a great job of treating people with chemotherapy, radiation, all of the amazing treatments that have allowed us to have 18 million cancer survivors. But we don't always help people deal with all of the other aspects of cancer and how it affects their lives. And that's really what we're going to talk about today, is how do we help people live well after their cancer diagnosis and that survivorship journey. I'm really honored to be with three exceptional leaders here today, and I'm going to give each of you a chance just to give a little bit of your background and your organization. So I'll start with Dr. Vadaparampil.
Perfect.
Yay.
Good morning, everybody, and thank you so much for the opportunity to be here. It's inspiring that you're all getting up on a Saturday morning to come and to really soak up some of the information and knowledge that's here. I'm at the Moffitt Cancer Center in Tampa, Florida. I've been there for 22 years. I started as a faculty member with a research interest really in population health. And areas that I've worked in are many of the ones that Dr. Temkin mentioned in terms of screening and early detection. But during my time at Moffitt, I really started to understand that that's one part of the cancer continuum, and have also transitioned my research to consider survivorship. So what are the needs of individuals because they are surviving cancer in the areas of fertility, fertility preservation, genetics, just to name a few. I serve as the Associate Center Director for Community Outreach and Engagement. All of our cancer centers do, I would say, the best possible job we can in regularly engaging with our community to better understand what do you need from us, and to take that back to our leadership and to make sure that it gets incorporated into what we do. And I will say, with our last assessment, one of the things that came through loud and clear from our community was survivorship and doing a better job once people finish treatment. So happy to be here with you today. Dr. Licht?
Thank you, Dr. Licht.
Good morning, everyone. I'd like to thank Congresswoman Wasserman Schultz and her office for bringing us all together, and for you sharing your stories with us today. And my regards to the previous speaker, who was really quite inspiring to all of us. I'm a medical oncologist. I'm a physician scientist. I've been at the University of Florida as the director of the Cancer Center since 2015 and was honored to work with my colleagues to make the University of Florida the 72nd NCI designated cancer center in the country starting in 2022. As a Cancer Center director, I oversee and collate all the different aspects of cancer research and care across the whole university, engaging almost every college of the university, including diverse colleges of journalism and communications, law, arts, engineering, medicine, dentistry, etc. So we've taken an all-of-university approach, including very important aspects of communicating with cancer patients and understanding the best ways to get the best message to the best person, the best time in the cancer journey, whether it's survivorship or screening or the treatment itself. I would say, in my perspective as a medical oncologist over the past 40 years, what's really exciting to me as a medical oncologist is seeing so many cancer survivors, seeing those people in my clinics, seeing them on the wards, seeing people who certainly would not have been with us if we had the half dozen or dozen chemotherapy drugs that I used when I first started. So it's remarkable to me to have even personal stories. I had dinner a month ago with a friend in Massachusetts who's an 18-year multiple myeloma survivor. I have such people in my clinics now. This was unheard of when I started out. And so for us as medical oncologists, it's really important to begin the survivorship journey from the diagnosis onward to rationally and honestly give appraisals to the patient of what's the goals of our care for you. Are we going to have this tumor stay away for a long time? Is it going to be a short time? How do we guide them on that initial journey? And then when there is a really favorable outcome, how do we work with the patient and the primary care physician to see what the next expectations will be? We have some very powerful drugs and more powerful ones. Immunotherapies such as my colleague Dwayne Mitchell is developing at University of Florida, and Moffitt has really pioneered things such as the CAR T-cell therapies. But they have very potent side effects as well, and we need to educate our patients on what to expect and to educate our primary care providers in the community on how to best manage that patient on the forward journey. So again, thank you for the time today to discuss this with you. I'm pleased to turn out my old friend Frank Panuto, who we were together in Illinois for a number of years as well.
That's right. Good morning, everyone. I'm Frank Panuto. It's a pleasure to be here. Thank you to the Congresswoman and to Patrick and the organizing group for bringing us together and talk about a topic that's near and dear to so many of our hearts. I'm trained as a clinical health psychologist and in behavioral medicine. I've had the privilege of leading our cancer survivorship and supportive care programs at the University of Miami since 2018, where I came down from Northwestern in Chicago. I have to say it is a privilege, and we work tirelessly every day to address many of the concepts that Susan and John have raised. We always conceptualize survivorship as a journey, and we try to convey very clearly to our patients that we're joining that journey with them from the first day, the day of diagnosis, through the balance of their lives. With that in mind, we are keenly aware that at diagnosis and during treatment, we want the issues and concerns to be laser focused and making sure the patient has the most optimal treatment available to them, that they understand what to expect and what comes after. But right alongside that process, survivorship begins to kick in. We start informing the patient of what services we have available. We're very fortunate to have comprehensive care available for our survivors that begins with a very systematic and methodological assessment of how they're doing through our patient portal or when they come into the clinics, when we're not only monitoring physical side effects or toxicities of treatment, but we're also asking about their emotional well-being, their social connections, their social health. And based on how they respond to that, we have systems in place where we can triage our patients to the necessary resources, not only within our cancer center, but also within our community with a vast number of community partners that we work with. We have also been able to develop and implement survivorship wellness clinics with my colleagues, Dr. Kalfa, Dr. Perez, who are here today. And those are very specialized clinics that do not replace oncology follow-up and care, but complement it, and complement it in ways that they address factors that the reality of many oncologists, they may not have the time to spend with the patient to address, whether it's comorbidities like obesity, lifestyle behaviors like smoking, or even just understanding what the follow-up is. What is the risk of a secondary cancer, bone loss related to endocrine therapies? So we work very closely together with a multidisciplinary team. We learn from each other, from our colleagues across Florida, and collaborate with them to make sure that we're giving our survivors the most optimal chance of having the best quality of life possible.
Thank you. I really appreciate that that you talked about survivorship beginning from diagnosis. And I will say that the founders of our organization, when they got together back in 1986, they really came up with the concept of survivorship and the term survivor from diagnosis. I think that's so important because a lot of times people will think of survivorship as this thing after treatment, and it really begins with treatment and the decisions that are made and the patient's understanding of what those potential side effects would be. And as you said, Dr. Licht, really what are the goals of care in making those treatment choices. One of the things that we advocate for is a survivorship care plan that helps people understand, here are the treatments I've had, and here's how it could affect my health going forward, and here's what I need to do to reduce the risk of recurrence, what kind of screenings I need. But really that starts with a care plan at the beginning, not just at that transition to post-treatment survivorship. And we know that not everybody gets these plans, but what we hear from survivors is it would be a really important tool. I'm interested in your thoughts on why survivorship care plans are important and what are some of the barriers to making sure that everyone has one. I don't know who, Dr. Pinedo, do you want to start?
Sure, I'll start. So back in 2015, the Commission on Cancer implemented a standard 3.8. It's very fresh in my mind because it was a pretty high bar that was expected for every Commission on Cancer accredited cancer center to deliver survivorship care plans for 100% of their patients. Excellent concept that made sense to all of us. Cancer care is highly variable, differs across from one patient to the other. There's an enormous amount of detail, many treatment teams involved. So it just made sense to have a unified document where all this information would be available for their patient, and also, I think, very importantly, for their primary care providers and other specialists, so that they would be able to effectively communicate with one another and understand what this patient had gone through in terms of treatment and what to expect. As you can imagine, the capacity of cancer centers, even NCI top-tier cancer centers, it just wasn't able to meet those standards. It just took a lot of effort to be able to meet the 100% compliance. So the Commission on Cancer sort of retracted, and we were a bit bummed, but I think the silver lining is that they said, you don't have to give a survivorship care plan to all your patients, but you do have to provide comprehensive survivorship care. And what that involves is prevention, intervention, care coordination, and surveillance. And it has really helped us refocus our resources and our energy, not only into getting those care plans, which are critically important, and we still strive to provide it to every survivor, but also have a more patient-centered and targeted approach at providing these holistic services to all our patients. So in our experience, it has led to a lot of advances across many institutions, where now it's not only about your follow-up care, but also lifestyle, nutrition, and physical activity. Emotional well-being, your mental health, how is that being affected? And I think that's been driven by that initial drive to have a survivorship care plan for everyone, and then refocusing on the comprehensive care that now we're delivering.
Yeah. Does anybody else want to add to that?
So to follow up, after those guidelines changed, there was a survey of all COC accredited facilities. So that's about 1,400 in the US. And only about less than 50% said that they do survivorship care planning for every patient. But to the point that was raised earlier, many more of them offer coordinated survivorship services. And at the end of the day, that's probably the most important thing to make sure that survivors are sort of transitioning to that next juncture. There is benefit in terms of improving provider knowledge, patient knowledge, to have a comprehensive document that summarizes, this is the care that I had, these are the expected potential side effects, short-term, long-term. I will say there's been a little bit of a resurrection with AI and some other technologies, because part of why this has been so challenging is how time-consuming it is for a healthcare professional who, really didn't have an easy way of pulling that together. So hopefully, that helps in terms of that starting point, but I really like the spirit of where the COC guidelines are going, which is that all of our centers have to do better in getting people to that next phase of the journey.
Yeah.
There are some good resources. The American Society of Clinical Oncology is one source where you can download a customizable care plan, and you can, in fact, I asked Chatbot to make one for me today too. So you could do it on the fly with Chatbot or one of the others, and it didn't hallucinate, it was okay. So I checked it out. But the fact is that there are some things, if you're a patient who you could say, I've had multiple myeloma, I've had drug A, B, and C, what are some of the side effects I might anticipate? If you've had bortezomib, for example, there's an elevated rate of cardiovascular events, so you may need to have more cardiovascular monitoring. If you've had immunotherapies, you might have autoimmune thyroiditis or other endocrinopathies, things like that. So there are ways to do this. There are templates. There are some guides through AI, I agree. One of the big problems, I'd say, is the electronic health record, which is one of the great morasses of our time, is extremely difficult to manually pull things out of it. AI tools would be great to say, scan this and tell me what the real salient points are, because there's a lot of extra words in there that are just decorate the record. But the idea of trying to bring together, now it's a way to potentially empower yourself. You as a patient or caregiver can bring down these forms and have an organized way to say, who was my radiation therapist, who was my medical oncologist, who's my surgeon, and what are some of the things, you could work in the collaboration with your care provider to help fill out that form. And as medical oncologists, I will tell you this, as a medical oncologist, I've led a division, I've led a cancer center, I practice. There is a great demand for our ability to treat the patient who needs active therapy. There's not enough of us. And so as much as we are following patients for a period of time and surveilling, we do need to have patients go back to primary care providers, because there's too many patients coming in the door, unfortunately, that need acute treatment. So this is something that you can work with your primary care provider and oncologist to develop.
Thank you, Dr. Licht. I wanted to talk a little bit about who should be providing this survivorship care, because as you said, there's not enough medical oncologists to keep following patients. We know patients want to keep seeing that person that they've developed this relationship with, who've saved their life. And we also hear from oncologists, they want to see the bright spots in their day of these people that they've treated that are doing well 10 years later. But there isn't that there's too many people who need active treatment. However, we do a survey every year called our State of Survivorship Survey. For all of you survivors in the room, if you go to our website, we are cancernation.org. Our current year survey is out right now, and you can complete it and share your experience. We ask people about, are they in follow-up treatment? And only about 2/3 of the people who are 5 years out or less say that they are receiving follow-up care. So that means 1/3 of people who are less than 5 years out are not receiving any follow-up care. And then we ask, who do you go to? And we've actually seen a decline over the last 3 years of people saying that they're comfortable seeing a primary care doctor. And I think, and the reason when we ask that is they feel like the primary care doctor is not going to be able to catch the cancer. So one of the things that we're doing is we're going to conduct a survey of primary care clinicians and oncologists and try to understand what are the barriers. We hear anecdotally that primary care docs say, we don't have the time, we don't have the bandwidth. They have so many other things that they have to address with their patient. And then we hear others saying, we're happy to do that as long as you tell me what I need to know. And that's where a care plan would be helpful. But all of it's anecdotal, so that's why we're going to do a survey and ask and try to have some representative samples. But I'm interested in your thoughts on how do we empower primary care clinicians to take over that care or work in conjunction with the oncologist, and what do we need to do to make sure that happens so that the medical oncologists can focus their time on the people who are in active treatment?
So I can speak to some of the work that we're doing right in that space, and I should say there's also a shortage of primary care physicians in the state of Florida, so it's a double-edged challenge. So we were very fortunate to be funded by the NCI to work with Health Choice Network, which is a network of federally qualified health centers that provide primary care services to South Florida communities, many of them underserved communities, through collaborations within our cancer center led by Dr. Kalfa, who's here, Jessica McIntyre, who couldn't be here today. We've developed a primary care provider training plan in collaboration with Health Choice Network. These are CME accredited modules to help our primary care providers. Of course, it's part of a bigger study where we have a cluster randomization of clinics trying to implement survivorship care services within those primary care clinics. But what we've learned is the obvious. These sites are under-resourced. They have a lot of challenges. Their primary focus is dealing with cardiovascular health, infectious disease, dual diagnosis with substance abuse, and so forth. With that said, we have been able to pivot and make sure that we're providing very targeted knowledge that helps us identify and ideally risk stratify the patients that need care. I have to say the biggest challenge we have is where does their care stop and where does it go back to an oncologist in that primary care setting? And that's been difficult to articulate just because cancer has so many different diseases, so many different scenarios. But there are initiatives out there, George Washington University, Stanford, University of Washington, Seattle, Fred Hutch, they've all implemented programs to address the issues with primary care practice because inevitably most of our survivors are going to end up being seen by those primary care providers.
I think the colleague-to-colleague ability to communicate makes it more palatable for a primary care provider to take back the patient and feel like they care for them. And so some of the model that we've been trying at Moffitt is that we're solely a tertiary cancer center, so we don't necessarily have primary care in the way that the other centers do. But we've been bringing on physicians who are in the primary care space that can become sort of that expert when it comes to survivorship. And so obviously it's not enough to take care of the thousands of survivors, but they also become sort of that knowledge base, that touch point in the community, so that as folks are going back, there's an easy touch point for somebody who works in that same space but has that advanced knowledge of our oncology patients, latest treatments, right? Immunotherapy, there's things we just don't know yet. And so that's also our effort to be part of the larger healthcare ecosystem in the community. And I think that's a model on some level that all of our centers are trying to be for the broader patient population.
Mm-hmm. Do you want to add anything to that?
Well, I think it's really important to have those clear lines of communication between the community provider and the oncologist, because being able to have that communication in case there is a suspicion of some recurrence or a side effect or something that needs to be discussed. So I think those networks are really important, and to have those lines of communication open. A lot of one thing I do caution some patients, for example, particularly in some diseases, there's a constant scanning and rescanning, and I'm like take the gas off that a little bit, because CT scans, for example, are a whole lot of radiation, and there are estimates that there are now cancers being induced by constant surveillance CT scanning. So there needs to be, in terms of monitoring the patient for recurrence, this has to be, there could be symptoms, there could be signs, but not like our previous panelist who has the Li-Fraumeni syndrome, but for the average patient, surveillance has to be moderated against the risks of over-radiating, for example.
So what would your advice be to someone, a cancer survivor who maybe feels like they're a little bit lost in transition and doesn't have the resources or the knowledge to manage their care going forward? Because it really is a burden on cancer survivors to manage their care. And they may have coordination, but they're the ones really kind of dealing with all the potential different specialists that they have to see. And maybe they didn't come to one of your centers for their care, but now they feel like they don't have that follow-up. What would your advice to them be? I know you talked about how they could kind of create their own care plan, but what about just getting the follow-up care that they need?
I mean, I think organizations like yours are an important resource within the community of sort of where to begin. Mm-hmm. It's interesting because I know this more from the screening and early detection literature, but the biggest predictor of whether or not a patient gets something, does something, is if the physician recommends it, but the second biggest predictor is if a patient asks about it. Mm-hmm. And so I think it is very reasonable for a patient to ask for, these types of services. And at the end of the day, I always feel like the intent that anybody went into these helping fields is to help patients do better and feel better. So, that would be step one. But I also think, there's a lot of patient support groups, finding out who is the doctor that's following you, sort of connecting with patients either through advocacy organizations, support groups, Facebook, sort of support organizations, probably are some of the low-hanging fruit, I will say, for patients. I don't know if others.
Yeah, I would completely agree, and it goes back to that initial touch point with the patient and improving patient engagement and education, and having the patient understand from the get-go that whether it's a survivorship care plan or talking about the concept of survivorship and transitions of care needs to begin early on. Thinking as a patient, the last thing you're thinking about is what's going to happen after treatment. Your cancer diagnosis, it's a shock to the entire system. You're wondering if you're going to survive this. How is treatment going to affect me? You're not thinking about who's going to have a summary of the treatment that I received, what comes 6 months, 5 years after that. So I think engaging the patient, educating them, and as Susan mentioned, it's not only the physician, but also empowering the patient to know what to ask for from very early on would alleviate some of that. And of course, working with organizations like the American Cancer Society and others which have resources to navigate the patients.
Mm-hmm. I do think that the survivorship issues differ from different types of cancers. Someone who's had hormonal therapy for breast cancer may be facing bone loss issues, loss of secondary sexual characteristics, of things that, of body image, things like that. That's a particular thing. People with, my patients with myeloma have terrible neuropathy, and they may need to see neurologists. They may need to use special medications, which work sometimes. So it's a matter of customizing a bit. And I think the medical oncologist, from my point of view, can help guide and say, these are some of the side effects you may have, and I'm going to help you with these, but some of them may go away. Some of them, if you're going to be on, there's some medications we now use in myeloma, we keep people on for years and years. We play around with the doses, we adjust it a little bit, but they're keeping the tumor away, and we think that's better to have that maintenance. And that's a new kind of survivorship, of having long-term maintenance therapy. People on the same, these pills, thalidomide-like drugs, lenalidomide for years, and they're having some symptoms, but the other hand, if I can tell them those numbers are very low. I don't see anything coming back right now. There's a little bit of a trade-off there, but so each kind of survivorship is a little bit different. I do encourage in some of the patients I see, they're long-term survivors. I have a running joke with them. I say, okay, you're 72 years old now, and your cancer is really in remission. Let's work on that cholesterol. Let's work on that alcohol component. So I say, you need to become 80 so you can run for president.
Oh my gosh, please no. I think that's a really interesting point, though, because once you have that cancer diagnosis, that becomes like the thing, and often it's other factors in your life that could be as challenging, I guess, or to your health, especially in long-term survivorship. Which makes me think about, Dr. Pinedo, you mentioned the wellness clinics or visits, and we know that cancer survivors want to know what can they do to reduce their risk of recurrence. And we know a lot of things that they can do, but there's not always the time to educate them on that. So can you talk a little bit about the best ways to do that? Maybe you don't have time in the survivorship visit, but you do it in these other ways to help people use that diagnosis as a way to make some of the lifestyle changes that can help reduce the risk of recurrence.
Yeah, absolutely. And again, a diagnosis and treatment, these are pivotal points in an individual's life, and it's a point of opportunity to address a lot of these other issues. It's not only about taking care of your cancer and making sure that you're doing all the right things in terms of follow-up and adherence to your medical visits, but also understanding the role of nutrition, the role of physical activity, smoking, alcohol consumption, which, as we know, the guidelines have been updated to zero alcohol. Things that we know are modifiable. I don't agree either, but we have to go. But that's the new guideline. Yeah, that's true. But just making sure that they understand, because we do some work in cardiometabolic health and cancer survivors, and a lot of that work is traditionally focused on understanding late effects of treatments, primarily in pediatric and adolescent and AYA survivors. But there's a lot of growing interest not only in those populations, but also in adult populations, and how these cardiometabolic factors are not only associated with recurrences of cancers, but also just mortality. And on the one hand, we're seeing advances where patients are living longer, but cardiovascular disease is not going away. So going back to the awareness for the patient, education, and a point of intervention when this is some of the benefits that can be found in a cancer experience is just reinventing your lifestyle, reinventing your path forward so that you have good outcomes.
Yeah.
I wanted to just piggyback on what Frank was talking about in terms of wellness with that recently. This was pretty groundbreaking for people that do physical activity research in oncology. There was a study published in the New England Journal of Medicine where there was a little over 800 colorectal cancer survivors that were randomized to, meaning they either got a pretty rigid 3-year exercise sort of program that they participated in versus health education materials. And so this was the first study that showed improvements in overall survival at 5 and 8 years for those individuals that were engaging in the more structured exercise program. So that felt pretty empowering to know that, something that we could potentially have some control over made a difference in terms of lifestyle. And one of the things that we're doing at Moffitt, you had asked about sort of community partners and networks, is that we've partnered with 2 of the largest local YMCA branches in our area to sponsor their survivorship and wellness program. So now it's called YMCA Survivorship and Wellness, powered by Moffitt, where we are able to bring our expertise in exercise, diet, nutrition from our faculty and our researchers to really infuse that into the 12-week survivorship program and conduct additional research on what do survivors want. The biggest thing was nutrition. So we're working on adding a nutrition component as well. And, talk about partnership. That's the way we're going to reach more people. They have 330,000 members, and they cover counties where 50% of our patients come from. So the beauty of being able to refer to a partner that is in the area so that we have something to offer our patients once they are done with active treatment is really kind of fun and empowering.
Yeah.
And things are rapidly moving in terms of nutrition and in terms of ideal body weight. Recent studies from our population science group at University of Florida have shown that the use of GLP-1 agonists for diabetes and weight loss is associated with lower cancer risk, potentially lower cancer recurrence. And we understand more and more that being above ideal body weight is more and more of a risk factor for new cancer diagnosis and probably recurrence as well. So I think use of those agents, which an increasing fraction of populations on, we're about on the edge of getting oral GLP-1 agonists, oral Wegovoys or Ozempics. This is going to be something that it's got to be used judiciously, because some people can lose so much lean body mass that they can't support themselves. They'll lose too much muscle as well as adipose fat tissue. So that's going to be a new challenge, because we're going to see people in the survivorship space who are taking these drugs as well. So it's going to be a new challenge for all of us in the healthcare professions. But I think these are great ideas. I think what I'd like to imbue in some of my trainees is to always think, I'm an internist before I became a medical oncologist. When I see patients in follow-up, I like to ask, I still do a review. Well, what's happening? Do you have headaches? Do you have any chest pains? Do you have this or that? This is this is the thousands of patients I've seen over my career that I think about every part of the body. So I think that's really a good part of medical oncology, is to think about that and to try on those return visits, even if it's a cancer visit, to be aware that the rest of the body is there. And that's one reason why I like my own field of medicine.
Yeah. Whole person care is so important, yes. I wanted to open it up and see if anyone in the audience has a question. I believe there's someone with a microphone. Okay. Let her go, yes. I'll get to you next, yeah.
Oh, thank you so much for being here today. I am a survivor, I think it's 14 years now. And my question is about bone density. What do you recommend for somebody that is in negative osteoporosis? And my PCP recommended taking, at this time, vitamin D, like 50,000 units a week. And also possibly Prolia. I recently had some back surgery, and my neurosurgeon said that he had to stabilize my lower area because I fractured the L5, and he had to anchor the screws and rods, one rod into the pelvis, because he said my bones are so weak and brittle and like spongy that he fears that it could break again. Not again, but it could break. And so my concern is, I'm going to be 60. What do you recommend for my diet? Do you recommend Prolia shots? Because I'm scared, and I've got really bad scoliosis. So I'm healthy. I exercise. I swim. I try to keep the weight down. I want to live a long time, and I don't want to end up in a wheelchair. And I do have a lot of secondary effects from tamoxifen. I'm experiencing a lot of neuropathy and just referred pain, like all over. So what do you recommend? I'm not into taking the drugs. I try to do the health path, natural health path. So I know I'm giving you a lot of questions, but if you could, because I'm just so excited that I have some really talented people to ask today. So if somebody could give me some answers.
Well, maybe I'll take a crack at this. It does sound well. First of all, we're really glad that you're living long and living the best life you can. So congratulations on that, and we'd like to try to help you. The bone loss is a real thing for every woman after the menopause, and if you had a anti-estrogen therapy earlier, before the menopause, you start to lose bone even quicker than if you had maybe natural menopause. So it's a real thing. There are bisphosphonates, Prolia, there's weight-bearing exercise, walking, things like that. It seems to me there are, here in South Florida, I'm sure there's many endocrinologists who are sort of bone health experts in particular. You would need to have periodic bone densities. And the thing about bone density is it's very machine dependent. You should get a bone density done pretty much on the same machine each time because you go different places, they calibrate it differently, so you have that monitored. In my own family, there's a lot of osteoporosis. My wife, my mother, my late mother-in-law, so my own spouse takes Prolia. It's been helpful. She's had bisphosphonates in the past. There are complications of that. She's not a cancer survivor, but just a very small bone person. So I think she's had great success working with bone endocrinologists in particular. They are very used to this kind of thing. I'm sure there are many such specialists here. I say in terms of, it looks like you're doing a marvelous job with your weight. I think swimming is great. I think weight-bearing exercise, swimming is a little bit lateral, maybe kind of walking, maybe some, treadmill, elliptical. Those might be things to think about as well, because you want to put some stimulus to the bone that keeps the bone growing. So that's my stretching my internal medicine knowledge is here, but that's the best I can offer right now.
Thank you. Do we have time for another question, Patrick? Yes, go ahead.
Hi, it's Carmen Calfa here from Sylvester, and I have the privilege to work with Dr. Pinedo, Dr. Perez, and I have an amazing team that we all care for survivors from day one through their life. So I'm involved in working with Dr. Pinedo to develop the survivorship wellness, the survivorship multidisciplinary clinics. And I've been aware of this lost in transition now since 2005, right? So 20 years later, we're still talking about it. And when you ask the patients who do they want to be seen by, I think all of them still want to hear from oncologists, and I think you just saw that. So for anything, they would want to check in with us. We get the messages from everything about every cold. If it's not from the patients, it's from their physicians. So I think, transitioning them, it's really hard unless you give the primary cares, not only the education, which we're working on modules and all that, but the 15 supportive services that we have built for our survivors, and we have them at major cancer centers. And when you look to see how we built them, most of them are built on philanthropy and grants. And I applaud Congresswoman Debbie Wasserman Schultz for really advocating for survivors and making these services reimbursable and payable, and patients can get them. But you cannot transition a survivor to just the primary care and pull that rug with all the services that you have available at the major cancer centers, because they won't do well. Just giving them a survivorship care plan that summarizes the problems that they're going to be facing without really having a plan in place of who's going to address every single one of them, it's going to be very hard. So I think one part of it is that it's probably a full transition. I don't think it's going to happen for multiple reasons, including the fact that they can't just take on all survivors. But I think a loose transition, and then having our mid-level providers work in the cancer centers with us and be that intermediary clinic in between the oncologist and the primary care with subspecialty, cancer-specific support services dedicated for all the survivors, I think will take us the longer way. Thank you.
Thank you. Is there time for one more? Okay, thank you very much. We are out of time, but I really want to thank all of you for your expertise and for what you're doing to help cancer survivors in your centers and for being here today. Thank you.
Hello to everyone joining my friend, Congresswoman Debbie Wasserman Schultz, for her second Cancer Survivorship Summit. Debbie and I have partnered to support people with cancer at all stages, from successfully passing the Bipartisan Early Act and its reauthorization, wouldn't have happened without Debbie and her tenacity, which we are proud again to lead, to our years of involvement with the annual Congressional Women's Softball Game, which has raised more than $4.3 million for the Young Survival Coalition. Debbie founded the game, and I have been the announcer, along with Dana Bash and Andrea Mitchell, for several years. After years of working with Debbie on breast cancer prevention, it became personal for me in a very different way. Following a routine mammogram in February of 2021, I learned that I had stage 1A breast cancer. I'm lucky that I just had stage 1A. So many people are fighting tougher diagnoses. I got out of it with a lumpectomy and radiation, and after that, and 4 months later, I was in remission. I know how you have to have those checkups over and over again. When they found another small spot, I was able to do the same thing again, and after just a few more rounds of radiation, I'm once again cancer-free. It didn't used to be like this, but as we've paid more attention to breast cancer over the years, more women than ever are beating the disease. Mortality declined 44% from 1989 to 2022. I think we can all agree that's a good thing. Currently, there are more than 18 million cancer survivors in the U.S., and 22 million are expected by 2035. Whether it was a less serious case like mine or Debbie's, where I still remember, Debbie, when you came to tell me, and I think only like your roommate knew, of course your family knew, and asked me to keep it quiet as you were going to announce the Early Act and that serious bout of cancer that you dealt with pretty much on your own with that incredible strength and courage. But anyone who has survived or is surviving cancer knows that it isn't always as simple as picking up where you left off. Surviving cancer may mean transitioning back to a primary care physician with a whole host of new health considerations and follow-up appointments they might not be aware of. It can mean returning to the office or searching for a new job after a long gap on your resume. It can mean having to navigate work, school, home life with lingering health challenges or treatment side effects. These can be tough obstacles, but cancer survivors are tough, and with the right support, these challenges can be overcome. That's why Debbie's work on survivorship is so important, and that is why we're fighting to pass legislation that takes a wide-reaching approach to helping survivors tackle these challenges as they come back from the biggest fight of their lives. I truly believe that we can get this done for cancer survivors who manage and beat this cruel disease. After all, Debbie has never been one to back down from a big fight. She walks right into it, and she gets it done. Thanks again to everyone for coming together to support cancer survivors. Enjoy the rest of the summit.
Please welcome Dr. Sue Friedman, founder and executive director of FORCE, and Dr. Carmen Calfa, medical co-director of cancer survivorship at the University of Miami Sylvester Comprehensive Cancer Center. They will both present on demystifying and dispelling myths about cancer genetic testing.
Okay, I think we have 10 minutes to demystify that. You can start, sorry.
So we'll demystify it in 10 minutes, apparently. So I'm Carmen Calfa from Sylvester Comprehensive Cancer Center, and I'm so grateful for this opportunity to be here with you today. I made a new friend who I had her book on my desk. I just never met Sue in person. And as we're preparing for this talk, I just learned so much from her, and we're just talking about how much more we can do together. So next slide. I'm just going to let Sue start with her story, which is so inspiring, and they got us where we are now.
Thank you so much. I am just so grateful to be here. Thank you for the invitation. I'm grateful to be anywhere as a 29-year breast cancer survivor, 2-time, and thank you. And then when I thought I was kind of home free, I was diagnosed with an aggressive thyroid cancer, likely due to the aggressive radiation that I had had many years before. So, you know, the issue of survivorship is really important to me. Next slide. So this is me at age 33, so 29 years ago. Cancer caught me out of the blue. I didn't really have a family history of, certainly not of breast cancer. I was fortunate to be diagnosed at 33. I found a lump which was benign, but it led me to the path of getting early detection, of having mammograms, and a mammogram found microcalcification a few years later when I had a young child. And cancer wasn't on my radar, and I didn't have a lot of resources. I was young, and nobody talked to me about genetics. I actually read about genetic testing for BRCA in a magazine article, and I had a lot of the red flags, but my healthcare professional never mentioned it to me. I did end up halfway through treatment getting genetic testing and finding out that I had a BRCA2 mutation, like Representative Wasserman Schultz. Presumably we're related way back. And, you know, even when I was finished with treatment, that wasn't the end of it. That mutation meant that I was at risk for other cancers, so I had to make a lot of very difficult decisions. I also ended up being a caregiver to my father, who I got the mutation from, who ended up having aggressive prostate cancer, and he succumbed to it. So, I mean, you know, and even now in my 29 years of survivorship, having to be screened for pancreatic cancer. So this is really a lifelong issue. I didn't really mean to start a nonprofit, but actually soon after I finished treatment, and when I was making decisions about what to do about my breast cancer risk, my ovarian cancer risk, I really needed support. And so that was the reason I really started to try and bring together a community of people with inherited cancer risk, and kind of accidentally along the way started FORCE. So I've now been doing this for 26 years. I'm no longer a veterinarian. I no longer practice. FORCE has been my full-time passion for the last 26 years. And along the way, things have changed a lot. They've improved a lot. They know, you know, these days they test for more than BRCA1 and 2. But I thought we could bring to you some of the myths that we still hear now, 26 years later, and really kind of dispel some of those myths about genetic testing. Next slide. And the next slide. So one of the things that we hear a lot is the idea, and I think this was brought up before, that especially BRCA, but that genetics only affects women, and that's not true. Next slide. And the fact of the matter is that half of all mutation carriers in BRCA1 and 2 and Lynch syndrome and many of these other genes that increase the risk for cancer are males. And men or women can pass on the mutation to their sons or daughters. So this is really important. I got my mutation from my dad. Next slide. The second thing is that, you know, only people with a family history, I talk to a lot of people and they say, I don't have a long family history. I was the first one in my family to be diagnosed. So was I. Sometimes there are red flags. You could be the first one in your family, but it's still, that doesn't mean that you don't have an inherited mutation. Next slide. And there are some rare cancers that can be a real red flag for an inherited syndrome, and Dr. Calfo is going to talk about those a little bit later. Next slide. The other is that genetic testing is expensive, that it can't be, it's hard to afford, and that health plans won't pay for it. And next slide. The fact of the matter is that most insurance companies will cover genetic testing, but even if you don't have coverage, most people can access genetic testing for $300 or less. So that's, back when I was tested, it was thousands of dollars, but today it's a lot more affordable. Next slide. The other thing that I hear is, why would I want to know? There's not anything I can do about it. And next slide. The truth is, no matter where you are in the care continuum, whether if you've never been diagnosed with cancer while you're in active treatment or even in your survivorship phase after treatment, there are benefits to knowing if you have a mutation, both for yourself, for surveillance, for prevention. But even in treatment now, there are targeted therapies that work particularly well in people who may have a certain type of inherited mutation. So it is important to know. And then even after you finish treatment, it's important to know, both for your risk for other cancers, but also for your relatives, because it can help inform them and they can make proactive decisions about their health as well. And so next slide. So with that, I'm going to turn it over to my wonderful colleague, Dr. Kalfa, to talk about some of the facts.
Thank you, Sue. And those are just a few of the things that we hear every day, or why you shouldn't, or all the fears related to that. We put together a couple of slides, not because we wanted to know all these numbers, but just to make a couple of points, which I think are changing almost every month. And in a way, I'm going to just start by saying that's one of the hesitations I have when we say transition patients fully, because we learn every day new things that we didn't know before, and they're just not going to be on everybody's survivorship care plan. So when you look here, every type of cancer, and there are some of them, potentially could be linked to a genetic mutation or predisposition, and that's all data. Now we know that even multiple myeloma can be linked to the BRCA gene. And we learned that lung cancer actually can be 15% if you test, they're going to be BRCA2 positive. So that's changing almost every month. There is an article here that is really one of my favorites and is most quoted, and now it's getting to be old by now, but it says universal germline and tumor genomic testing needed to win the war against cancer. Genomics is the diagnosis. So when we try to be as proactive as Lainey told us this morning that we should be, we should know everything we can about our own risk. And knowing that risk many times involves knowing your family history on 2 generations up and down, and potentially knowing your genetics. Next slide. So there are signs possibly of inherited mutations, and then they could be all those that you hear, the red flags, like male breast cancer, patients on the father's side that everybody died of pancreatic cancer. I had seen patients with breast cancer, stage 4 at 39, and when you ask them, they said, no one in my family has cancer, because the only thing they could think of was breast cancer. And yes, indeed, no one had breast cancer. She was the first one. Everyone on the father's side died of prostate cancer before age 50. So those are like things you need to know. There are many things in there. And then we spoke again about other associations with different syndromes, cancers, genetic syndromes, endometrial cancer, with colorectal cancer, breast cancer. So those things that potentially just look right and left, mother, father side, 3 generations. If you see a lot of cancer and you're not sure, there is a way to know if you are at increased risk. And I'll tell you the phone number you can call later on. Next. So the other thing that you see here, it's usually guidelines are behind, right? So if you just apply the guidelines, even as they are right now, half of the positive mutations will be missed. So the guidelines are always lagging behind, and by not knowing, you potentially can miss an opportunity to diagnose early or do the right thing for you and your family. So these graphs are showing that if you test those that met the criteria or those that didn't, the chance of finding the gene was equally high there in the 7 and the 8 rate. Next. So what are the benefits of genetic testing? So it allows you to have the right screening, start at the right time. A patient that has a BRCA gene, if she starts at 40 with her mammogram, she'll be 15 years late for her first breast cancer screening. The risk reduction, she potentially could do all the screenings that she needs or the risk reduction surgeries, including, bilateral salpingo-oophorectomy, or just removing the tubes at the right age. The cancer treatment depends on having a gene or not for most cancers these days. So even for that purpose, it's important to know. And then the childbearing and fertility options. Many people have this guilt of, I feel so bad to know that I passed it on to my child. And one thing that I realized make people want to know is knowing that actually the choice of passing it on to the next generation is still there for the families that haven't completed their childbearing age. And through IVF and assisted reproductive fertility, people can choose to select the embryo that doesn't have the genetic mutation. Therefore, that part of the information it's available and is very, very important for many. Next. The process is easy. It's blood, saliva, can be sent to your home. You can do it in many ways, and in 2 to 3 weeks, you know the results. Next. So the breast cancer, we traditionally know that the BRCA1, the BRCA2 could potentially be linked to that. And, they're high penetrant genes, meaning the risk of developing the breast cancer, ovarian cancer is really high. But as we learn about families that in the past, they were all with breast cancer in the family, they all tested 10, 15 years ago, actually. And they're negative for the BRCA gene. They're in a way reassured that they don't have it. And they're like, I don't have it. I tested. My daughter had tested, doesn't have it. So upon retesting those families, we learned that they actually carry different genes, like the PAL2, the CHEK2, the CDH1 if they have a gastric cancer and breast cancer. So retesting those patients that were initially tested with a small panel is warranted for many of the patients that initially had the reason to be tested for BRCA. They're negative and they had a small panel. Next. So this is just showing you right here on the right side that if you just test for the BRCA, you actually have the red bar to the right. And if you test for the rest of the genes, you double up the incidence of finding a pathogenic mutation. Those are equally important to know about. Next. So just not to overwhelm anyone, but to just show you the complexity of these genetic syndromes and to really guide you, and hoping that today you're going to really want to know everything you can, but then if someone has a pathogenic mutation, you're going to look for a program that can actually take care of you in its all complexity. And this is just showing you the syndromes. And the BRCA1 and the BRCA2, I think most people are familiar with, and you know that it's the breast and ovarian cancer. It can increase the risk of male breast cancer, pancreatic cancer, and others. But as you look at down, the Lynch syndrome is also very, very important. And you see all those like 5 genes that are there. It comes with colorectal cancer, endometrial cancer, and look at the time, it's 10-fold higher than the general population. So we have even a Lynch syndrome clinic at Sylvester looking for these patients with really high risk for colorectal cancer and endometrial cancer. But Lainey, I want you to hear me, hopefully from somewhere, how inspiring your fight and your beauty in so many ways, and how you face all this with gratitude and resilience, and how much you inspire us to really do more for our patients every day. And I thank you for that, and I wish you only the best. So hopefully you hear that. I really wanted that syndrome to be there for all of you. And look, just read that, what it says on the left. You see the 7 to 20% de novo? It just means that it can happen just sporadically. And that's the live from any, that syndrome that Lainey told you about, that she had survived 7 cancers. It can give you all those cancer types. So if anybody has in the family multiple cancers at young age, sarcoma, brain tumors, and all that, just don't dismiss that possibility. And if you're negative for the BRCA, just make sure that we are looking for the live from any as well. Now, next. So I told you about the CHEK2 and the PAL2. Those are the newer, relatively newer genes that are a little less penetrant, but can also explain breast cancer in the families. They come with other cancers that the risk is higher for. So again, people should know about if they're BRCA negative, do you need more testing? How long ago you had it? How many genes were tested? Do I need more? And if you need more, now panels include 70 genes or hundreds of genes in our genetic department. So you can test for all this and retest as new genes become available. So in that survivorship care plan, we should just say there, as of now, panel of 10 genes was negative, to be looked again in a few years. Next. So you see the rest of them. I'm not going to go through all of them, but the last one is the CDH1 that, gastric cancer with lobular cancer, breast. So just know that it's not only breast and ovarian. If that wasn't there, then it's a no BRCA, then it's no gene. Next. So what did we do at Sylvester? Philanthropy leads to saving lives because allow us to build programs and do research that otherwise potentially would have taken longer to be done. So I had a patient who had a BRCA gene. She succumbed to the disease, but she would bring every patient by hand to me and said, I want to take care of this one. I want to take this patient, navigate her through or him through. There are male coming to my breast cancer clinic say, can you test him? Or, he has the gene and now we don't have a protocol. So we build a program based on coordination of care with a concierge navigator, research, prevention, education, and survivorship. And we call it GPS because the genes are trying to take it to a place. Genetic Predisposition Syndrome Clinic, thanks to Eileen Newty's family. Next. So this is just showing you how that GPS clinic is gene-based, and it's a bi-directional collaboration with all the experts at Sylvester, and you see around is the high risk. So we have a high risk huge program, and Dr. Perez, is leading the breast program there that you see care all the way up, and our team is here as well. So thank you everybody for doing all this. But as you could see, every one of the sites that potentially could be at increased risk, like GYO, GI, neuro-oncology, everything is connected. So if it's a gene-based, patients are home, then that becomes almost like the primary care for that particular gene. And then if they're not gene-based but still high risk, then we have all the high-risk programs built around. Next. So Congresswoman Debbie Wasserman Schultz has been always very supportive of this and worked with us closely. You can see her right there in the middle in the picture at the cutting ribbon ceremony that we had for the program. And you see some of the programs listed there with the support service being the last, but we have every aspect of it included in our multidisciplinary expertise and circle of friends, as I call it, at Sylvester. Next. So now we're going to pass it on, and you hear what's available nationally through the leadership of Sue.
So thank you so much. Just a few things about FORCE, facingourrisk.org. We are a national organization. I physically live in Florida, started FORCE in South Florida. Our 4 pillars are education, peer support, public policy, which is both federal and statewide. It was a point of pride. We've been working with Susan G. Komen and other organizations. The state of Florida just passed a law covering supplemental breast cancer screening with no out-of-pocket. So that includes high-risk screening. So that's part of the efforts that we do at FORCE. And then research, we connect people to studies that are enrolling people with inherited mutations like BRCA, PALB2, Lynch syndrome, and even Lee-Fermini. Next slide. So just to wrap it up, the most important takeaways, number 1 is know your risk, follow the recommended screening, know about the programs in your area, and I wanted to point out Sylvester's program, and you can call 305-689-RISK or visit their table in the Resource Center. FORCE has a table there as well, and with that, hopefully, we've accomplished demystifying this in maybe 15 minutes. I don't know if we have time for questions.
Thank you, everybody.
I can't read that sign back there. Do we have time for questions? I guess we do. Yep.
Hi, good morning, everyone. My name is Grace. I'm also a FORCE patient advocate, a volunteer, so thank you. Nice to formally meet you, and thank you also, Dr. Carla, for your information. So I do genetic education research in the University of North Carolina, and I'm trying to move my efforts down here to South Florida and wondering what have you seen within the community, or what needs do you think the community needs for there to be more awareness around genomic education, genomic health literacy, especially finding genes that can eventually lead to cancers down the line?
Thank you for that question. To assess the needs, I think we can look to see what's the rate of genetic testing and genomic testing, and you could see they're low. So that shows that the gap is there. We try to work on that gap, and we work closely with the community, and we organize a biennial precision medicine conference. The next one is April 11. I didn't want to plug that in, but you made it perfect for me. So April 11 and 12, and we brought the patients and the patient advocates for their own venue alongside the healthcare provider venue, because we learned that patients were coming to us for second and third opinion, really end of life, and they did not have germline or genomic testing, many of them. So that was kind of a heartbreaking thing. And we had national studies or precision medicine that potentially otherwise they could have qualified. So we took the initiative to really organize this educational event where all healthcare providers are coming. We're going to live stream internationally this year in an attempt to really make that gap as small as we can. But appreciate your advocacy and everything you do.
And I'd like to add in thank you for volunteering and working with us, and would love to talk to you a little bit more. We've also been working with the state cancer control program, and I think there's a lot of opportunities there to outreach into the community and raise awareness, especially about genetics and genomics.
We have time for one more question right here.
Thank you. I'll make it really quick. Dr. Calfa, thank you. You mentioned the relationship of multiple myeloma to BRCA. Can you just tell us what is known about that? That's something new to me.
It's very new thing to all of us, and it's just emerging data that there is an advocate in the room, actually, that she almost led to work being done in that field. And just like lung cancer is now showing an association about 15% if you test. The studies, I even listened to our geneticists speaking on that. Depends on how you test to prove that point or not. But there seemed to be an increased association if you were to test every multiple myeloma patient. So the small cohorts that were tested, it seems like the association with the BRCA2 is there.
And I'll add something too. We have a program called X-Ray where we kind of look behind the headlines. We actually did a plain language summary of that study, so happy to direct you to that because, as Dr. Calfa said, when you're looking across all multiple myeloma patients and then testing the genes, it tells you that 15% have BRCA, but that's not the same as saying if you have a BRCA2 mutation, that's your risk. And so my understanding is the lifetime risk for someone with a BRCA2 mutation for some of these other cancers is still pretty low. Is that right?
Agree, but there is an association or an increased incidence.
We can take one more question.
Thank you so much. Hi, and thank you both for being here to answer these questions. I was curious about something Dr. Calfa said regarding PALB2, and you said that was a newer genetic test. Is it newer like the last year or two? Like if genetic testing was done 3 years ago?
It was in the panel that was done about 5 years now at least. So it's included in the smaller panel. You don't have to go all the way for the 70 or higher gene panel to find the PALB2. So it also mimics very much the BRCA2, but if you just had a test for the BRCA1 and 2, would miss it. The smaller panels, the larger panel than just the 2 catches already the PALB2. Thank you for that question.
And I would encourage you, if you've had genetic testing, to get a copy of your results. Look it over, talk to your healthcare professional, because it will list the genes that you were tested for on there.
And just know the recommendation change, and the BRCA2 now, it's recommended to have pancreatic cancer screening. Well, a few years ago it wasn't. So just stay on top of it and see your genetic counselor or the GPS clinic once a year. That's also a recommendation, not to just do it once and then forget about it. Continue to do it as there are updates, including CHECK2, where the colorectal cancer screening was actually now downplayed as opposed to, do more, now we can do less. So just making sure that everybody knows that checking with the genetics is not a one-time. You have to continue seeing them for the updates.
Thank you for your questions.
Thank you. Thank you, everybody.
Please direct your attention to the screen for survivorship story videos from special guests.
Welcome, everyone, to Congresswoman Wasserman Schultz Cancer Survivorship Summit. My name is Alonzo Mourning. And I am so pleased to share our cancer stories and struggles and hear from experts who deal with survivorship issues that we all confront. A great place to start is to tell you all how this disease impacted my own life. Just a few years ago, I faced my own battle with prostate cancer. Thankfully, I beat it last year. It was as difficult as anything I faced on the court. But that experience allowed me to see how fortunate I am to have a network of support and resources. And it inspired me to be an advocate for other survivors. There are so many people who walk around feeling great, and they have cancer inside of them and they don't even know it. I was one of those guys. The only way to find out is to get tested regularly. While prioritizing my routine annual physicals, my doctors noticed that my PSA was elevated. I was asymptomatic, and I felt great. I thank God that I've been proactive with my health. I wouldn't have known it until it was too late. I'm glad to be able to share some of this with you, but as you all know, we have to turn our stories into action. My friend Debbie introduced bills that will tackle so many of these survivor issues in her comprehensive Cancer Survivorship Act. It's a great place to start solving many of these challenges. Obviously, we have a lot of work to do. But I'm confident that each of you will leave today more inspired and more focused on ensuring cancer survivors are never left on their own on their journey. So thank you again, Debbie, for inviting all us together here to do this work. And thanks to all of you who have dedicated yourself, your time to improving the lives of so many others. God bless you all.
Hi, everyone. I'm Andrea Mitchell from NBC News. As a cancer survivor, I am so pleased to be with you to share my experiences and offer encouragement to any of you going through this ordeal or taking care of family and friends. I flunked my mammogram 14 years ago, just as I was heading to Iowa to cover a political event in advance of taking a lead role in NBC's coverage of a presidential campaign, a highly sought assignment. I'd had no symptoms, I was devastated, and I had no time to absorb the shock before getting on a plane. I couldn't tell any of my colleagues, and I just tried to soldier on through the weekend on the road. But while getting ready to interview Congresswoman Debbie Wasserman Schultz, I must have conveyed my stress. Before the cameras rolled, she looked at me and she asked, "What's wrong?" I teared up and whispered, "I'm in trouble." Her empathy and quiet support meant the world to me. I'm here to tell all of you that we all need to be present for each other. That's why this conference is so very important. I was biopsied and treated in New York at Memorial Sloan Kettering, missing the first primary debate, but with constant support and encouragement from the president of NBC News and all my colleagues. The president of NBC's wife was a breast cancer survivor. He wanted me to know my job and my high-profile assignment would be there for me however long my recovery took. I was lucky. Unlike close friends and relatives, my cancer was stage 1. It was treatable. When I returned to anchoring my show, I announced my diagnosis so that I would have ownership of it rather than be subject to rumors or social media reports. But like many of you, I am frightened every time I go for a checkup. I always worry about a recurrence. To increase my odds of remaining healthy, I work out. I eat well. I stay strong, although I don't get enough sleep because of the unpredictable hours of my profession. What I have learned along this journey is the importance of community, especially the mentorship of other survivors like Congressman Wasserman Schultz, for whom I am forever grateful. So my lesson is, try to stay strong, be healthy, be there for each other no matter what happens. And special thanks to all of you for organizing and taking part in this important event.
Hi, everyone. I am so happy you're participating in the Cancer Survivorship Summit this year. Thank you to Congresswoman Deborah Wasserman Schultz for being such an important figure for this event. Obviously, I have been profoundly affected by cancer, having lost my husband when he was 42 to stage 4 colorectal cancer. My sister Emily died a couple of years later of pancreatic cancer, and I myself was diagnosed, thankfully, at a very early stage with breast cancer in 2022. It's such a challenging disease. 1 in 2 men will be diagnosed in their lifetime, 1 in 3 women. And we need to really focus not only on more research, more cancer research, but also helping families who are affected by this disease, because as we all know, it just doesn't affect the patient, it affects the family as well. I have the utmost respect for people who are advocating to help people who are dealing with this disease. I have so much respect for the scientists who are working tirelessly 24/7 to come up with better treatments and therapies, but also better diagnostic tools, because early detection really is the key in so many of these cancers. Anyway, I'd love to join you one year. I'm sorry I can't, but my heart is with you, and I wish you all the best as you continue to explore these critically important areas. And hopefully, one day, somehow, we'll find a cure for cancer and at least better therapies so we can manage the disease in a more effective way. Anyway, thank you to all of you, and hopefully next year I can join you. Bye.
Please welcome Dr. Timmy Nguyen, medical oncologist at Cleveland Clinic, for a presentation on mental health.
Hello, everybody. My talk is going to be on mental health in cancer survivor from an oncology's perspective. I mean, I have to admit that I had neglected the importance of mental health in cancer survival. I often underestimated the impacts it has on cancer survival life. I couldn't believe, for me, cancer survivor or individual who survived from the cancer at the time of diagnosis, during the treatment, and after the treatment. And in clinics on location, I see patients who first diagnosed with cancer are very anxious, and I attribute it to the common normal reaction of having diagnosed the cancer. And when they go into treatment, the anxiety still persists. And I would think that the anxiety and the over-demanding behavior eventually would go away once the treatment is completed. But after some of these patients who complete their treatment and remain cancer-free, their anxiety still persists. And then we realize that we have neglected an important aspect of their cancer care, which is the mental health that's associated with their cancer diagnosis. Next slide. So what's the mental health that's most impacting cancer survivor is the anxiety and depression. And it tends to be prevalent in cancer survivor compared to the general population. And those with anxiety and depression tends to have a negative impact on their lives. Mainly leads to lower quality of life. It causes survivors to have non-compliance with the follow-up cares and tests. Neglecting follow-up cares and tests tends to lead to later diagnosis of recurrence, and that will also cause more complication in terms of having successful treatment for their recurrence. And having prolonged stress and anxiety can also has been shown to increase the risk of cancer recurrence and decrease survival. And having an elevated stress and anxiety often leads survivors to having unhealthy behavior, including poor diet, lack of exercise, smoking, and abusing alcohol. And it's been reported that having chronic stress that increases cancer recurrence by promoting awakening of cancer cells, where it's often inhibited by the immune system, and stress prevents the inhibition of the immune system on these cancer cells, thus leading to recurrence of cancer. Next slide. So what are the causes of anxiety? How are these anxiety and depression are caused by cancer survivor? Often, anxiety is triggered by, as I mentioned earlier, abandonment, where patients are being seen during their treatment on a regular basis and watched very closely with examination and tests. And once they completed their treatment, they feel they're neglected. Right now, who's going to watch over me? I used to be seen and do my blood tests every week. How do I know if the cancer coming back? I'm not a health professional to detect this. So they're quite fearful that no one's watching over them closely to make sure the cancer doesn't come back. And this points to the fear of recurrence, because once, after completion of treatment, often a survivor will ask, what's my chance of the cancer coming back? And when it's not zero, I mean, that 1, 10%, 50%, that would create some anxiety. I mean, I could be this 1 to 10 patients that will have the cancer come back, and would create a lot of anxiety. And the anxiety can also be a traumatic event they experienced when they were first diagnosed with cancer. Occasionally, some of these patients, when they presented with a cancer, had a very memorable traumatic experience, like they're vomiting up blood, they have severe pain that they never experienced before, they had to have emergency surgery, and had prolonged hospitalization where they had difficult recovery. This is still vivid memories that they can remember, and often triggered by instances that they see on TV and watch life and express their fears and anxiety. And some survivors never recover from their previous self, where they suffer with chronic fatigue, chronic pain, neuropathy, that they're unable to enjoy the normal things they used to do in life before they were diagnosed and undergone a treatment, like playing tennis, golfing, these activities for some of the active patients that I see. Especially those with the body and image tissue after having certain surgery like mastectomy, hysterectomy, abdominal scar, and liver and ostomy and prostate surgery, where they're not the same person that they were before, that they strive to be. And occasionally there's a social and strained relationship that patients express, where they say that people around them don't understand what they're going through, and it's difficult to interact with people and they feel isolated. And of course, the last is financial stress, where occasionally some survivor has to pay for the treatments and has to stop working, especially if those are self-employed, because they have to go to treatment or they're not well enough to work. Next slide. So how can we best limit the impact on the stress and anxiety on survival? First is to initiate it early. Well, first to recognize and initiate a diagnosis early at the time when patients are diagnosed with the cancer, doing the treatment after completion of treatment. And when patients are found to be in high distress, they benefit the most from intervention. And these are a survivor with high distress when they're diagnosed, or they have poor quality of life during their treatment, or have poor social support system. Next slide. So one way you can assess who is at risk for having anxiety and depression through this patient questionnaire that we do in clinic every day is to have patients fill out this questionnaire. The first 2 questions deals with their anxiety. If they experience these symptoms or these feelings every day, almost every day, or loss of interest or feeling depressed moves every day, they are at risk of having anxiety or depression disorder, and would benefit from early mental health therapy. Next slide. So what are the mental type therapy that we can refer to? One is to change the behavior and way of thinking. Is that psychotherapy to work through the personal feeling and the coping of their cancer and what they're going through, and to change the negative thought pattern. Keep constantly having negative thoughts about, no, they're not going to do well, they won't get better. And often involve family or couple therapies to help with the dynamics of the family, where often patients are estranged or feel isolated. Next slide. But however, implementing a comprehensive mental health for a cancer survivor who needs it is difficult. One, because often patients, cancer survivors, do not share that they are in distress because they feel that this is a sign of weakness and a stigma that is not perceived favorably in the community. And also, as a provider, we lack awareness because we just focus so much on cancer treatment and how patients recover from their side effects and not think so much about their overall mental health, and feel that they will eventually get better on his own. And also, even though we do acknowledge there is some forms of anxiety or depression, that disorder involved, that we're not, as a healthcare provider, not equipped on treating them by the training we may not have, so we have to refer out to a specialist, and psychologists may be problematic because there's short supplies of specialists who deals with patients or survivors who have mental health issues. And as the panel mentioned earlier, that true comprehensive support of mental health may require good collaboration of the primary care, social workers, psychologists, psychiatrists that should work together and not fragmented independently. Next slide. Let's skip this slide, it's like a duplicate. And who should we target, especially those who are high risk of having distress under screening and depression, initially early when they're first diagnosed, early on doing a cancer diagnosis. That way we can pinpoint the source of the anxiety and the depression. Also, without having to refer to psychologists, we don't have the resources. We can ourselves try to do the normal things to encourage our survivor to bring joy to their life and do activity to bring joy to their life, to bring peace and distraction from what bringing them distress. And encourage them to seek out positive events like trip travels where they can look forward to, so they don't have to dwell so much into what's the current distress situation they're in, and definitely involve the community, family engagement, support groups where a survivor can learn from others who have gone through what they've gone through, and encourage patients to have good sleep hygiene, healthy diet, and regular exercise. Next slide. As the previous panel has mentioned, that after survival, healthy living a healthy lifestyle and exercise can impact the chance of recurrence. And this particular study that was recently reported this year, that patients with colon cancer who completed their curative treatment were asked to perform a structured exercise with with exercise coach that they meet every 2 weeks, every month for 3 years, versus those who was given information that this you could exercise 20 to 30 minutes a day for 5 to 7 days a week, and without any kind of life coach to encourage them to do so. So the people who have the structure exercise tends to be more compliant and consistent with their exercise program. And those with those structured exercise, with consistent exercise program, after 4 years or 5 years, that found that less cancer recur are those who maintain an exercise regimen under this structured exercise. So doing this empower survival that they can do something to decrease the risk of surveillance and help with anxiety and depression. Next slide. Well, this last slide kind of summarizes what anxiety and depression, how much it impairs cancer survival. So on this graph, on the level of functioning, once the survivor experienced the cancer diagnosis and treatment, they often lose the level of functioning. And if they faces the anxiety and depression and that's not treated, they will be at the bottom of the graph where their scum will never recover, never gain back the function, lives a very poorly quality of life. If they're able to have some kind of behavioral therapy or some kind of help with the mental health, they're able to gain some function with more optimal therapy and more optimal health, that they can gain back full function, even flourish beyond what they were before. And I guess we can put up there on the top of the graph is our Congresswoman, who is an amazing survivor, that she's thriving and flourish in that area. So just to maintain the importance of comprehensive care for survival with their cancer and also with their behavioral and mental health. That's it. Thank you.
We have time for a couple of questions. Please come in.
Here, right here. Ma'am. Excuse me.
Thank you, doctor, for the lecture. I'm a cancer survivor from endometrial, and I have experienced a lot of brain fog. The brain fog was so severe that it was really hard to sometimes do certain things that people do normally. You know, I will misplace things, and so my question to you is, I also working, and as a working level, I don't have that problem. I am organized. I'm a structure. I work from home at a very, micro level, and I don't have that issue, and I can perfectly function. But when it comes to my personal life, I still experiencing issues of brain fog where I misplace things, or I don't know if I'm distracted or anxiety. Is this something that is common when you have side effects after cancer treatments? And what type of treatment you recommend for me to follow up? Because I think I need help. Thank you.
Thank you for that question. Brain fog and chemo brain decay is quite common, especially early on why individual gets the treatment and afterwards, because the treatments and chemotherapy is still in our system and causes damage to our system, part of our brain that's still recovering. And it tends to persist for individuals who tend to have a pre-existing condition like dementia, and that's more difficult for those to recover. But you're also someone who's probably fine before and underwent treatment and still has some lingering effects of her brain fog. There may be some component of anxiety that is not manifests as underlying anxiety that is there, that sometimes patients may be suppressing it, not thinking about it too much, but it comes out in other means. So definitely would seek talking to a therapist, delve more into feelings and what's involved, what's behind the brain fog. First to speak to the chiropractor to diagnose the problem, but generally occasionally it's more to repress anxiety that subconsciously you're not thinking about your cancer, and that would inhibit your full brain functioning.
We have time for one more question.
Hi, thank you. I just had a quick question. When it comes to addressing the entire family unit, because cancer is such a familial disease where you have caregivers and you have siblings who are also being affected, how do you recommend that oncologists and healthcare professionals best address the mental health needs of the entire family beyond just the patient themselves?
Yeah, that's a great question. I would do that every day because it's very difficult dynamic, because occasionally you have family feels that the patients are not doing what it takes to get better, and the patients often with this conflict back and forth. Well, no, I'm eating better, and no, you have to eat more, you have to drink more. No, I'm doing the best I can. That's the problem, and it's hard to conflict. And if you don't want to have it to pick one side, because that can alienate other family members or the patients, where they feel isolated and don't want to interact and talk more about the cancer with the family members. So pretty much have a family discussion, open family discussion, and set expectation and understanding with the family and the survivor.
All right, and that'll conclude our Q&A for this segment. Thank you.
Hey everyone, Brian Fitzpatrick here from Pennsylvania's 1st Congressional District. Cancer is a word that changes everything. And like so many of you, I've lived that reality. My big brother, Mike Fitzpatrick, was my hero. He was the strongest and finest man I ever knew, and the best I ever will know. He faced cancer with courage, with grace, and an unwavering devotion to others. And losing him was the most painful moment of my family's life. But his strength became my strength. His fight became my mission. And his legacy is the compass that guides me in this very cause. Today, more than 18 million Americans live as cancer survivors. By 2040, that number will rise to 26 million. Behind every one of these numbers is a story of resilience, of families standing shoulder to shoulder, of caregivers who never gave up. Survivorship is not the end of the battle. It is the beginning of a new journey. And that journey demands our commitment. And that is why, as co-chair of the House Cancer Caucus, alongside my friend, Representative Debbie Wasserman Schultz, we are leading the Comprehensive Cancer Survivorship Act. This legislation will transform what survivorship means in America. It will ensure that every survivor has a plan for care, that families have the guidance they need, that patients have the access to support, and that no one walks this path alone. This is more than legislation. It is a turning point where survivorship comes to mean not just surviving cancer, but reclaiming life, purpose, and possibility. My friends, cancer has stolen too many lives, broken too many families, but it has not taken our hope. Together, we can honor those we've lost, stand with those still in the fight, and ensure every survivor is empowered not only to endure, but to truly thrive. That is our mission, and that is our promise. And if we remain steadfast in faith and unity and determination, I believe with all my heart that one day we will not gather to fight cancer. We will gather to celebrate its defeat. God bless.
Please welcome Marai Salina, Director of Oncology Support Services at Memorial Cancer Institute, who will moderate a panel called Addressing Social Determinants and Unmet Social Needs. Joining her are Dr. Alejandra Perez, Director of the Brahman Family Breast Cancer Institute for the University of Miami Sylvester Comprehensive Cancer Center, Dr. Michael Hall, Chair of the Department of Clinical Genetics at the Fox Chase Cancer Center, and Dr. Loretta Edronzi, Vice President and Chief Health Access and Community Center Enrichment Officer at the City of Hope Cancer Center.
Thank you, everyone, for staying with us this morning. I know we're running a little late in the program, but I think all the information we are sharing here is very meaningful and hopefully makes a difference for all of you. So, as mentioned before, my name is Marai Salina. I'm the Director for Support Services for Memorial Cancer Institute. Through my programs with navigation, social work, nutrition, and all services that support the survivorship program, I have a strong connection to social determinants of health, as well as all the things that we're going to talk about today. So without further ado, I'm going to allow the panelists to introduce themselves and tell yourself a little bit about what you do and how SDOH is important in your career.
Hi, I'm Dr. Alejandra Perez. I'm a breast medical oncologist with Sylvester Comprehensive Cancer Center. I've been with Sylvester for 10 years, taking care of patients at high risk of developing breast cancer or with breast cancer. I've been in this community for 25 years. We take care of a very diverse population here, and social determinants of health is a very important topic and dear to my heart as a physician, Hispanic immigrant, and a woman. I can see why this is so relevant, and there's so much work we have to do. We've made some progress, but we're still far from where we have to be. We've made incredible amount of progress in cancer care, mortality reductions. In breast cancer, mortality is down by 30%. But we know that not all patient population has benefited the same, and that's a problem. When your mortality depends on your zip code, we have a big problem, and that's what's happening right now. So this is a conversation that is extremely important, and I'm happy this topic is discussed here today, and I'm very grateful for the opportunity to be here with you today. Thank you.
Hello, everyone. My name is Dr. Loretta Irunse. I am at the City of Hope Cancer Center, which is all the way in Southern California, where I live. So we live in Los Angeles. I am very appreciative of the opportunity to be here. I want to thank Congresswoman Wasserman Schultz and her whole team for the invitation, and I'm so appreciative to being on this panel. I think very similarly, social determinants of health is absolutely critical that we talk about. So I am a trained cardiothoracic surgeon, so I care for patients with lung cancer predominantly and esophageal cancer as well. You know, my job is to take the cancer out, as I say, but what I learned very early in my practice was that, you know, I could do my best to get the cancer out, to walk my patients through their journey, but if the social determinants were ignored or not acknowledged or not understood, then my care was very limited, if that makes sense. And so even very early on, I realized the social determinants had to be a part of my practice, like thinking about it. It was not enough to just to do the surgery well. It was also important for me to see the patients wholly, and that included their social context. And so for me, this is part and parcel of who I am and how I want to contribute to the world. I am also a health equity researcher, and so I think a lot about and we investigate how social determinants influence risk of cancer, biology, and even screening behaviors. Again, I think of social determinants almost like a vital sign. Like, you know, it's important for me to understand your stage of cancer diagnosis. It's important for me to screen. It's important for me to know those sort of different data points. But if I don't understand and support your social determinants, then I really, again, have missed the mark. And most recently, have a new, as was mentioned before, role as the Vice President and Chief Health Access and Community Enrichment Officer. And now I'm really excited about pulling these ideas into the system. I think it's one thing to think about it in my OR, it's another thing to think about it in my studies for the research, but now I want to influence it, have it influence how we care for patients in the hospital, in the organization, and certainly in our community. So again, I'm very appreciative of the opportunity to be on this panel with these illustrious folks. Thank you.
Thank you, Dr. Hall.
So good afternoon, I guess, everyone. My name is Michael Hall. I'm a GI medical oncologist at Fox Chase Cancer Center in Philadelphia. So I also came a little bit of a distance to get here. I also wear a few different hats, and I guess before I start talking a little bit about myself, I do really want to thank Representative Wasserman Schultz. Her whole team have made the investment of time and energy in bringing together experts for a wonderful event like this. I think anyone who's in the cancer field would agree. We spend knowingly so a lot of energy at the diagnostic stage of cancer and the treatment stage, and that energy often falls off and becomes more disparate in the survivorship phase, and we really need to spend more time focusing on the group of people who are in this room, because that group is only going to grow in coming years, and we need to be prepared for that. We need to help people head towards that time of their lives. But so as a GI oncologist, again, I also wear some other hats at my cancer center as a leader of our cancer prevention and control program, where we have a big presence in studying health communication, but also social determinants of health. I'm also the head of the Department of Clinical Genetics, and one of my primary areas of research over the years has been in understanding various factors that predict who comes in to get genetic assessment, who benefits from that information. How do we make that kind of information more accessible to the population so that we can use it to help decrease cancer risks and help improve screening and access to care. One thing as a GI oncologist that I've seen over time, I've been practicing now since 2008, and I think it's been in the news a lot. We've seen younger and younger and younger individuals in our country developing cancer, and developing cancers that we used to see in 70 or 80-year-olds. Now we're seeing, I take care of multiple pancreatic cancer patients in my clinic who are in their 30s. And as someone who treats cancer, but then as a genetics guy, it makes me scratch my head, because I know the genes didn't change in our population, right? We're still the same people as we always were. We're actually smoking less than we used to. So why are we getting so much more cancer than we did before? And that's why this group is here on the stage, is because there are things in our society, in our environment, there are things we're exposed to that we're not asking to be exposed to or have in our environment, but we need to figure out as a population what those factors are. And before I go on too long, I'll say one thing that concerns me as someone who does research in this field is we're never going to identify those factors or answer those questions unless we continue to collect really good data on our environment, our country, who lives in it, who lives where, who lives in an apartment building, who has cell phone service, who doesn't. And if we don't have those data, we can't answer the questions. And I am sort of afraid of current environments going on that we're cutting research, and we're cutting costs, and we're not going to be able to have those data to answer some of the very vital questions of why our American brethren are developing cancer. And if we don't have those data and we can't answer those questions, we're never going to be able to make our population healthier. So we have to all raise up our voices and say it's important to have these information, and because we want to all realize the dream of Representative Wasserman Schultz and my own state representative Fitzpatrick, who just spoke, that we want cancer to be in the past, and we want to celebrate the end of cancer.
Thank you so much. Thank you for sharing, a little bit of a background, and I think you definitely honed in into the importance of addressing this topic today. I think we can walk away with SDOH being factors, non-medical factors that obviously can impact attaining good health. To put it in simple terms, across a cancer diagnosis in general throughout the continuum. But I'm a little bit interested in your thoughts about what are those SDOH concerns that you see or think are important in the survivorship period after active treatment.
So when we look at health equity, we look at what kind of care my patient is getting. Are they getting guideline concordant care? Are they getting access to care, timely diagnosis, the best care that they can get? And all my patients have to get the same type of care. So we have to look at that fair and just opportunity that they all have to detect, to treat, to diagnose, and to survive cancer. So that's how I see it. I ask the question, are they getting the best care they can get? And you start seeing some of the differences. And like I said before, we've made an enormous amount of progress, but not everybody is benefiting the same. So you ask why. And of course, there are many factors, tumor biology, genetics, there are many things that we look at. But when we look at social determinants of health, you see that there are striking differences, and they really make a big impact on outcomes, or on cancer outcomes. So I think we need to normalize asking patients those questions. We need to, every opportunity we have to see a patient is an opportunity for us to find out more about those social determinants of health. So you ask about food insecurities, you ask about digital connectivity, you ask about educational level, financial toxicities that they're having, educational level. There are so many factors that we can look at to really really get a good understanding of who's that patient in front of you and how can I help that patient. It doesn't get more personalized than that. And we talk about personalized medicine, but that's really very personal to the patient. And that's how we have to really look at the survivor that we have in front of us, and how am I going to facilitate that survivorship journey, and provide all the resources, all the tools that they need to go back to as normal life as possible.
Thank you.
Yeah. Sure. Totally agree. I want to amplify everything that you said. I think, specifically, social determinants of health impact individuals across the cancer continuum, right? Period, end of sentence. Like, social determinants of health, as you mentioned, are the non-medical factors, like the non-medical ones that impact your medical outcomes and impact how long and how good you're going to live. And so I think, just as you were mentioning, social determinants, whether it is income stability or economic stability or food insecurity or health access or any of or your social context, really influences your risk of getting the cancer, right? The neighborhoods you live in influence the risk of getting the cancer. It influences your access to good treatment, guideline concordant treatment, like you said. It influences how well you survive it and your quality of life with it and after treatment. And they all influence every aspect of the continuum. And so, to your point specifically, it's just like, okay, so which of these should I focus on for my patient? It depends on the patient, but we've certainly got to be thinking about all of them no matter where we are in the continuum, if that makes sense, right? In our research program, we think a lot about the neighborhoods and environment and air pollution. That's our bag. Like, we love doing geospatial mapping and that sort of thing, right? To understand, like, hey, there's some communities that live closer to highways. There's some communities that live closer to incinerators. There's some communities that literally have higher exposure to carcinogens, the things that cause cancer. And so, when I'm in that context, I might be spending more time thinking and talking about those environmental exposures. But when we're at the survivorship, it doesn't mean that I ignore those, because there's some data now that suggests that they might influence, those environmental exposures might influence the chances that the cancer might come back. So even as a survivor who's been treated, we still have to be thinking about those. But now we should also be thinking about financial toxicities from the treatment, right? Like, do you have transportation to get back to your follow-up, right? Like, all of these things. So I think, to your point, it really is still being comprehensive in our assessment of the social determinant. Every time a patient comes into my office, they get their vitals checked. Every time. And it doesn't matter. Like, we're going to check your heart rate. We're going to check whether you have your temperature. I think we should also be thinking about, what is your social context as well? And with each patient, think about which of these might be influencing you more, and then supporting it. It's not enough just to ask. We then have to do something about it. And that is when we've got to start partnering with our community organizations and start really doing this lockstep, where not just health organizations or surgeons or medical oncologists, we are within a community, and we've got to be leaning on and leveraging those partnerships to really take good care of patients, I think.
That was excellent. And I just wanted to add on to something both my colleagues said and bring it a little bit back to an excellent and very moving question that was asked by a woman in the audience a few minutes ago about her managing mental health struggles in the survivorship setting, right? She's completed therapy for cancer, but or experiencing brain fog. I don't want to label that mental health, but brain fog, something that a lot of patients bring back, right? And our speaker very excellently pointed out that sometimes that's a mental health professional or access to mental health care that may be the first step for patients, but where the social determinants of health come in are We know that many cancer patients, whether you're 25 or 85, may experience these kinds of brain fog and other cognitive changes from oncology care. What kind of resources are available, and that the availability of those resources often very much depend on a number of level of factors. Do you have a representative like Representative Wasserman Schultz, who is pushing policy to say people who are getting cancer care should have access to mental health care, right? It's on a policy level that those kinds of things have to happen. Just, as patients or even as doctors, we don't always have that kind of pull. I have patients who I'm frustrated and stomping my feet because they can see me as an oncologist, but then when I recognize that they're depressed or they're having panic attacks or other things, and I try to refer them to one of my colleagues who works in the same building, their insurance doesn't allow them access, or they have maybe some sort of form of a Medicaid plan that doesn't cover mental health. It's incredibly frustrating, and the fixes for that, or at least one of them, is at the policy level, and it's at our elected representatives to say, this is something that we are neglecting, and we have to mandate. If we're going to mandate people have access to mammogram, or mandate they have access to genetic testing, they should mandate they have access to mental health care. And so I just wanted to bring that one example of these again, how these social determinants of health are so important to sort of all levels of cancer care.
Thank you. No, I think you all bring excellent points. I think it's strong to think that SDOH needs to be looked at throughout, right? But there are specific things that you might want to look at during the survivorship period or after treatment. I also love the fact that you brought up the idea of looking at SDOH screening as a vital sign, which is like a given. Anytime you come in, that's one of the things that we're going to talk to you about. So I'm curious to know, what are you doing to measure SDOH or screen SDOH in your institutions? And one thing that we also see a lot is the trust of the patient disclosing this information, because this is very personal, this is very intimate information sometimes. So I'm curious to see what are you doing for measuring and screening at the institutions, and if the trust has anything to do with that.
Yeah, I see it as three components, three parts. One is the individual level. What am I doing? How is that relationship that I have with the patient, which is extremely important because that involves the medical trust or mistrust. What can I do to really get into those aspects that are so important? The other component is the institution. At an institutional level, what is being done. And then the last component is community and the community involvement. How do we get those community leaders out there? And then above that, policy and governmental issues. For example, at Sylvester, we screen patients, and we have it incorporated in our electronic medical record, which is a good tool to have, but that involves a lot of resources, a lot of training of the staff, and it's a process. It's a process, but every patient that comes to our office gets screened, and we ask about all of those issues. And the important thing is not just to screen or to measure, is to have an intervention, like you were saying, because if you don't have an intervention, sometimes you can cause more harm than good. So yes, you have food insecurities, and too bad, right? What can I do for you? So you need to have those social workers available, or those community leaders available, or those programs, many organizations that are here, community organizations that are here to help us with that, because of course it's costly and involves a lot of resources. So I think at the institutional level, it's important that we have screening. There are guidelines out there. I know you've worked with NCCN looking at those guidelines, or how to measure those factors, food insecurities, financial stability, housing, transportation. How many patients cannot come to the doctor because they don't have transportation? Or in Florida, 60% of women are getting a mammogram once a year, only 60%. And why is it that they're not getting to a mammogram once a year? Something that we think is so easy and basic, but maybe they don't have transportation. transportation. Maybe they don't have childcare. Maybe they don't have paid time in the job. So we have to look at all of those things and incorporate it at every level of us as an individual, institutional, and community and government.
Thank you. Anyone else would like to?
Yes, I will say absolutely. We're doing very similar, the same things, asking social determinants of health questions in our EMR. Very much aligned, trying to create workflows to make sure that individuals' social determinants are being addressed. And then I think the next step is how do we incorporate that even into like our clinical practice? Like maybe I really do believe that we should be supporting and treating patients based on their social determinants. And this is sort of an early idea, but I think like if we were to measure that someone is food insecure, like we should think about how we incorporate food pantries and grocery support into their induction or their chemo or immunotherapy. Like that should be a part of it, like part and parcel. Or if we find that someone, their social determinant is that they are in a high needs neighborhood or low transportation, that is a part, like we have sort of flags that then say, okay, well, we need to support with a ride share funding and scheduling so that they don't miss their appointments on the back end. And I think that's when we will be doing, really quality, excellent care. I know sometimes right now the word equity is being threatened, but I still use it because I think the truth is all it means is when our excellent work has reach, right? Like we can have all the great treatments and we can have the best research, but if it doesn't have reach, if it doesn't get to the communities who carry the greatest burden, then it's not excellent. And so I think for the way I think about things is very similarly, like let's just make sure that what we're getting gets to the folk who need it. And I think specifically to your question around trust, like it's huge. I think the reason people don't have trust is because health systems have been untrustworthy. So the truth is communities are smart and they're like, you messed up. Like literally there have been issues between you and my community for a while. And so I'm smart to be reluctant. Like there's wisdom in the fact that you've harmed me in the past. I'm not just gonna let you harm me easily now. And so what I hope for us is that we will become more trustworthy. That literally, we always talk about communities needing to trust us more. I think we need to be more trustworthy, and part of the ways you do that is to see patients wholly, right? Like not just their diagnosis, their stage, but like understand their environment and who they are. I know that for me, I want you to see me. I want you to see all of me, right? The maybe a little funny, definitely serious, African-American woman who works hard, right? But none of that, I don't want you to ignore any of it, right? Like the whole me. And I think when people feel seen, then they can trust. And so I think that's a part of it. And so we are doing a lot in that space in trying to really hear and listen and see communities and understand that the truth is the answer to many of the problems the communities already know, right? We just have to listen and partner. We have the data, sometimes we have the funding, but they have the lived experience. So when the insights plus the data get together, we can do beautiful things, but it really has to be a partnership. So I think that would be my answer to that part of the question.
Thank you. Dr. Hall, anything you'd like to
Sure, and I'll
add?
just add a couple things that I think, like my colleagues, my health system, I think we do, I would say, a reasonable job in asking the appropriate questions about social determinants of health, and we ask them at each visit. I wish sometimes we had more time to spend on those so that they didn't feel sort of checklist-ish at the beginning of the appointment. Is your housing okay? Is your transport okay? Because I think that, sometimes there's so much that needs to go into a medical visit that some things happen quickly. I do find, I'll get off my mental health soapbox and be a little bit on my social work soapbox, that I think often as a provider, I find a lot of the arrows of when I identify social determinant of health issues with my patients, a lot of those arrows end up pointing towards my incredibly hardworking but incredibly understaffed social workers at my institution. They are the most sort of undervalued individual in the team in terms of finding resources for patients and navigating patients towards those resources, and they serve both as, again, as experts in finances. They serve as experts. They're shoulders to cry on sometimes. They're mini mental health professionals, but yet I'm sure my colleagues would probably say the same thing at their cancer center. My team in GI could use 10 more of the social workers I have. And it's because that's, they're just sort of undervalued, and we need to value that more because they are so important. I do think, in terms of, and then, them helping point us towards resources, I think we still have a lot of work to do to develop the resources that when we identify our SDOH, the food insecurity, the transport issues, sometimes we identify them, then we're like, well, now what do we do? What do we do? And there are some great examples. And at my own institution, a couple things that I feel like we've started to do better. So we have a partnership with a ride-sharing organization. So if a patient has that barrier that they can't get into my appointment, we can send, I won't use one of the names of I don't have any preference of ride shares, but we send one of the cars out and they can bring the patient in. And we've helped bridge a gap there. Similarly, we've been very fortunate. I know there was an American Cancer Society representative here. American Cancer Society has a Hope Lodge right near my institution. So folks who have housing issues related to trying to get to their radiation appointments, which may be 5 weeks in a row or something, that helps solve that gap if you can't afford to stay in a hotel or something like that. One other plug for my state, Geisinger, which is a wonderfully progressive health system in the central part of the state, has started a kind of a food pharmacy if you do have access issues to getting healthy and nutritious food, that there's an ability to get food through an access point that the health system says this makes sense to invest in, right? Our patients are going to be healthier. We're going to spend fewer healthcare dollars if we actually provide people with nutritious food rather than what's otherwise available in central Pennsylvania, which is often McDonald's, and I shouldn't say that, it's a commercial organization that's not always focused. They're focused on flavor, not on nutrition. So I think those are the things. Last point I'll make is back to this idea that I do think it's a space to meet that need of how we address SDOH in our patients. Is there are a lot of wonderful private organizations who do a lot of great fundraising, spend a lot of time, have a lot of experts who provide those resources. There's a great one that provides resources to my patients called For Pete's Sake, which provides respite care for young patients who are effectively dying of their cancer. And so it's that that kind of community-based advocacy, similar to what Sue Friedman does with Force and others, to people recognizing in their own community, in their own society, the importance of having these resources, getting people together, fundraising, and then providing those resources to other cancer patients. I know we'd all like everything to be able to be funded by our government or our local or our national government, but we have to face it, it's probably never going to happen. So organizations that step up and help us do that are really remarkable.
Thank you. Thank you for sharing your insight. At least some points that I took with me from what you share and your expert opinion is that we don't only need to look at screening and like identifying what the needs are and the barriers, but also having in place options that we can give the patients and resources. So I am biased because the social work team is part of my team where I work. So definitely I would advocate for a lot of more social work, to be present and be available for patients and help them overcome these barriers. But what do you think would be some policy actions that we could ask for in order to help with SDOH and survivorship?
Well, there's a long list, and you heard the Congresswoman, everything that she's doing in terms of like the Early Act or genetics, survivorship care. So there's a lot of work being done. I think one of the biggest changes that we've seen was really in regards to access to care and like the Medicaid expansion. When patients have health insurance, of course they get better care. So that's one thing that we still need to work on, trying to get patients to have health insurance. And I know that's tricky and there's a lot of politics there, but Medicaid expansion proved that was a good intervention. The other thing in policy is that has also shown very good changes is the navigation programs. So if we can get more help for the navigation programs all over, so every patient in America has access to a navigator that has shown to improve access to care, to decrease mortality because they have timely care. And patients, of course, are going to feel better navigating systems that are usually very complicated. We need help, for example, with telehealth. There's a lot of issues right now with telehealth. If my patient who is a Florida resident goes to North Carolina, I cannot do a telehealth visit because I don't have a license in North Carolina. So the patient has to be in Florida. There are a lot of barriers there. Patients in rural communities, who's getting to them? If we don't have access to telehealth, if those patients also are part of the connectivity divide, technology divide, if they don't have access to all of those things. So there are so many factors. The other thing that I think is extremely important to look at the policy level is what are we doing to improve the diversity of the workforce? If you look at oncologists in the country, only 4% of oncologists are African American, 6% of oncologists are Hispanic. So I think we need a more diverse workforce because that's going to help us with trust. That's going to help us with recruitment to clinical trials, which is another big point that I have, access to clinical trials. It is incredible that only 5% of minorities are represented in clinical trials. So we do all of these studies and we know how they work for the white Caucasian population, but they have no idea how these drugs or how these interventions work for Hispanics, for African Americans, because we have very little representation. And what I think is more striking is that implicit bias that we see all the time. When it comes to clinical trials, the main factor is that patients are not being asked to participate. It's been shown that when you ask an African American, when you ask a Hispanic or any minority to participate in a clinical trial, they do. They do when they can communicate with the provider, they can communicate, they can trust the system, they do, and we still have very little representation. So I will say access to care through health insurance, navigation programs, diversity in the workforce, telehealth, connectivity, and then I mentioned more, but I can go on and on. There's so many things that we have to tackle. So
Yes, no, thank you. Thank you for sharing that. So if it's okay with the panelists, I would like to open it up. If there's any questions within the audience, we have a few minutes left of the session. Yes, we have a question right here. I don't know if there's someone who can assist with them. Okay, we hear you.
Hi, my name is Esmeralda, and I have a sister-in-law that had cancer. She did die. Metastasized more than once. And I did try to get her to do other things to help the body, like you were saying. Other things to help the body, nutrition, where it sounds like tea is not where it is. As of recent, okay, thank you so much. As of recent, there is new technology has come to my attention. It comes from a former NASA scientist. And we actually had a testimonial of an 88-year-old with aggressive prostate cancer, and he was able to, for it to be gone. His PSA was 0. So obviously something like that would not only, work together with everything else that's being done, the nutrition, the treatments, but to keep the body, because it grows mitochondria, which is basically the key. So I don't know if the doctors are open to it. I'm more than happy to share that information. It's all about helping each other and keeping each other, in the right path. Because everybody wants to be healthy, and we all need it, especially after so much that's going on. I know cancer is supposedly increased like 300% after COVID shots and stuff like that. So I'm here. I'm here to help. God saved my life, and we just have to share.
Thank you. Thank you for that. I think we had another question over there. Thank you.
I'm really appreciative here when we talk about trust, because that's one thing I've observed as a clinician is that in the last 30 years there's been a big shift in trust. And
Thank you. What patients believe when you give them a recommendation based on a guideline, it used to be that they just trusted the expert or the clinician and they would follow suit. But I didn't think I heard much about the power of health beliefs or cultural health beliefs. And I think that I've seen a big shift in that. And I just wonder, what you can recommend for clinicians, how we can connect with people and engage them in their health beliefs and help to build that trust again, because it's not there.
I think I'll start, but I would love to hear others' ideas as well. Is that I 100% agree with you. Being a practicing clinician, and this is actually something my own research group has studied within the Fox Chase Temple Health System where I work. There has been an incredible erosion of trust in sort of the medical establishment as a large. And I think that is to some degree a greater reflection of just general distrust in institutions. And there's a lot of parallels there. When we've studied it in our health system, sometimes what I learned from the research we did is that mistrust or distrust, whichever one you want to call it, is certainly not just one entity. There are sort of various facets. There may be a trust of the actual the provider who comes in the room, who interacts with you, but then a greater mistrust of the health system and feeling that the health system is working against you, but you trust your provider has your back. Sometimes the mistrust is focused more on health insurance and how that may be undermining the health system and the provider, and so the focus is more on the insurance. But there are some groups who are really working to try to understand mistrust and try to develop interventions that will help us build greater trust in our community of patients. One group that I follow, whose research I follow because it parallels some of the research I do, does a lot of their work in the HIV positive population and understanding mistrust in that population towards effective medications to control HIV and other things. And one thing that they have really identified is getting the providers, getting the health systems, the insurers into the community earlier, to have dialogue in the community, to be seen as part of the community rather than some separate entity that, is kind of the person behind the curtain, dictating what's going on in your life. That seems to be at least one effective way of helping people feel that that I am part of a community, and these are the people who are here to help take care of me, and they actually do care about me. I'm just not a number or a financial tick. So that's just one perspective on this, but I welcome my colleagues as well.
Absolutely. I think it's a great question, and I totally agree. They're different levels, right? I've seen similar data where an individual might trust their doc, but not trust the institution. And the truth is, individuals and communities that have significant mistrust or distrust in the institutions, you're likely not seeing, right? And me neither, right? They're not in our office because of that distrust. And so the real question, at least for right now, might be, well, what do I do about the cultural beliefs of the person in front of me that's in my room, and how do we navigate that? And I think primarily one way is to really listen and to ask, and I've had individuals come in, I lay out the offerings, the options for their particular stage disease, and they're like, nah, I'm good. And I'm just like, oh, okay. So, and it's actually fun. I really just sit and relax. So I was like, oh, this is about to just be a conversation as if we were friends, or, you know what I mean? Because now I'm going to, and I really am like, please tell me what's going through your head. What are you thinking? What did you come in with? What, I want to hear your perspective. And I think some of that garners trust too, right? Because then you're building a relationship. And I think that's where real trust really starts. That's one of the reasons why there's such distrust, is because that relationship with these institutions isn't real. So I think, for the one-on-one, it's like, okay, so what are the barriers? What did you come in with? What would help this situation? What would help? Is there anything, right? I believe that I love data, so I love sharing data in a way that my patients can experience it. But at the same time, that might be the wrong data for them, right? They may not be thinking about 5 years, you know what I mean? And so I think, again, just really listening, understanding, trying to get to the heart and the root of the issue, of the gap. Just like if you were hanging out with someone and you felt like there was a distrust in your non-medical relationship, the things you would do there, I think we could try to potentially bring into our clinical environment. And then I would say, just sort of more globally, I think one of the ways, and I appreciate the research that you were talking about, because I believe that it's true that we need some sort of investigation in this space, but again, I think it comes with building that relationship. And I think people need to see that their communities are valued by the institution, right? I hear so often folks say, I went to my doctor every year. How is it that I'm stage 4? Cancer, right? And that breaks trust. It's like, I did what I was supposed to do, and my doctors didn't find it. You're a doctor too, so who am I? You know what I mean? What are you missing? Because they miss stuff. And so I think it's the whole, and not all of it can be easily fixed, but I do think if we can put language to, I get that, I hear you, I see, and I understand your concern, I understand your reluctance, I understand the pain, I understand the frustration, get to where they are, and then say, and now what I want to do is partner with you to get to the other side of this. And I think that would allow us to get to some of the cultural beliefs as well, when you're listening and when you're asking those sorts of questions. So anyway, those are the things that I try to do.
Thank you. I'm not sure we have time for one more question from the audience. Thank you all. Thank you.
Thank you all for coming. Since we're a little behind on time, that'll conclude the Q&A portion of this segment.
Hey everybody, it's Congressman Jamie Raskin from Maryland's beautiful 8th Congressional District, shouting out to my friend Debbie Wasserman Schultz and everybody at the Cancer Survivorship Summit. I'm sorry I can't be with you there in person, but I just wanted to send you my greetings and my fervent solidarity to all of the cancer survivors and people fighting this plague on the land. I remember when I first got cancer, the first time, because I've been around the track twice, but when I first got cancer, I read this essay by Susan Sontag called Cancer as Metaphor. And in it, she says, just in passing, that everybody's born with two passports. One, a passport to the land of the healthy and living, and two, a passport to the land of the sick and dying. And everybody at this summit has had to use that second passport. I'm hoping you come back and get to use that first passport again. But Susan Sontag said that all of us would like to be able to just use one passport, but in fact, over the course of our lives, all of us are going to use both of them. And I just think it's a matter of moral obligation that those of us who've been over there and see what it's like with people who are desperate and sick and on the edge of survival, that we remember what it's like and that we continue to act in complete support and solidarity of people over there. And I remember when I first got cancer and I saw the difference between misfortune and injustice. And misfortune is, having a job you love, a family you love, constituents you love, and a doctor telling you that, you've got stage 3 colon cancer and you could die, and that's a terrible thing, and it's a misfortune, but it's a misfortune that happens to millions of people all over the world every day. But if you're in a situation like that and you can't get the health care you need, you can't get the support that you need because we haven't set society up in such a way as to give you the support you need, that's not just a misfortune, that's an injustice too. So those of us who've had the hardship, the benefit of using both passports have got to remember that it's up to us to fight for justice for everybody, because life is hard enough with all the accidents and illnesses and sicknesses, all the misfortunes of life. We shouldn't be compounding it with man-made injustice. So hang tough, everybody, and best of luck to you.
Please welcome Dr. Haneen Habdallah, who specializes in pediatric hematology and oncology at Joe DiMaggio Children's Hospital, for a presentation titled Beyond Survival, Managing Lasting Impact of Pediatric Cancer Treatments.
Good afternoon, everyone. I first want to start off by thanking Congresswoman Wasserman Schultz and her team for bringing us together here today to not just focus on survivorship, but to celebrate it. And us as pediatric hematologists, oncologists are extra passionate about survivorship because our little ones have a long time to survive. And so we really try to focus on what we're treating, how we're treating it, and the late effects as they become adults, as they get into the workforce, as they have families, and God willing, grow old. What is their life going to look like, and how can we minimize the effects of the treatment we give them? So we start off by saying the reason that we care so much more about survivorship now than maybe 10 and 20 and 30 years ago is because so many more children are surviving childhood cancer, okay? If we can have the next slide, please. In the last, basically, 40 years, pediatric cancer survival has increased from 10 to more than 85%. Okay? Yes, yes. I thank all the researchers and patients that participated in clinical trials for being a part of that number. Okay? And so because more children are surviving childhood cancer, we have more survivors to take care of into adulthood. If you see here, based on this chart, you see the survival on the left-hand side, and based on many of the treatments, some of our treatments, Hodgkin's lymphoma, which adults deal with as well, has a survival rate that's over 95%. These are patients that we focus on improving the treatments we give and monitoring late effects. Because if you look at the graph on the right side, you can see the number of survivors over the years that are now going beyond into adulthood. There are almost 500,000 adult survivors of childhood cancer in the United States. So this is a huge population that we need to focus on, that our primary care providers need to be aware of. They need to be educated on cancers, their treatments, how we monitor the late effects, and what do we do if we identify late effects. Next slide, please. What's important here, can you click it one more time so we have that graph? Oh, no graph. Okay, no worries, you can go back. So it's very important to note, okay, 2/3, and some estimates even go higher to 3/4, of cancer survivors from childhood have long-term late effect, at least one, if not more. And 25% of these conditions were serious. We're talking grade 3 to 5 of these late effects. And so this is a huge number of survivors of cancer that have to deal with things like you mentioned earlier, brain fog. Seems like something that might be straightforward, but is actually quite intense and affects your day-to-day life. So we need to have our PCPs, primary care providers, family medicine docs, internal medicine docs, and beyond to really understand what we've given our patients and how they need to monitor for it. And we're going to delve into that today. Okay, so here you can see that there's this study where in the Lancet Oncology was published a while back, about 7 years ago, that compared siblings of cancer survivors to the cancer survivor. And you can see here, okay, the blue, red, and green, based on different decades during which they were treated, have much higher cumulative incidence of the toxicities, of the chronic health conditions than their equal siblings, okay? That's how they differentiate. Is it because of the cancer and its treatment, or is it just because of genes and because of how they, grew up or whatnot? So this is a huge difference. Next slide, please. And when we talk about the late effects of pediatric cancer treatment, and truthfully, it's adult cancer treatment also. This really can be, can go beyond. It's just that the kids have so much longer of a life to live after that, God willing, that, we are really focused on it. But you adult cancer survivors right here can be thinking about this. This is what all the organ systems, and this is not at all comprehensive, but this includes the concepts of what organ systems can be affected by cancer treatment. Medicines that we call anthracyclines, like doxorubicin, daunorubicin, if anyone got those medications right here, those can affect the heart into long term. You've got your hearing, cisplatin, carboplatin, that can really affect sensory neural hearing loss. Then you go further into secondary malignancies. The fact that you can get a cancer in the future because of the treatment that you got for the first cancer. It's a scary thing, right? And you can see there beyond respiratory system, like pulmonary fibrosis from things like bleomycin. Fertility, extremely important. That is something that I always bring up to my patients because I want them to know I'm not just thinking about this next month. I'm not thinking about the next 6 months. I'm thinking about when I get to go see your baby's, kindergarten graduation. That's what I want to know. That's what I want them to focus on. That's what we want our patients to focus on is the years ahead. And so fertility is a very important one for our children and your young adult cancer patients, right? So that's another one that we've got to pay attention to. And neurocognitively as well, right? Some of the treatments in leukemia for children, we give spinal taps, we do spinal taps, and we give chemotherapy into the spinal fluid. That can affect neurocognition over time, the ability to perform at school and all of those activities for the future. So these are all, needless to say, extremely important aspects of care. Radiation is one of those things that, man, I try to avoid as much as possible because it can affect many of these regarding to where you're hitting that tumor, with radiation beams. So just think about how important this is for our children and why the next part is so important. Next slide, please. This is again showing siblings against their the cancer survivor sibling, and it's just going into some of those significant things. You look at, they are, for example, hearing loss, right? The relative risk is 1.96 versus 0.36. The relative risk is 6.3 more likely to have hearing loss than their sibling. So these are just some examples that were published in the New England Journal of Medicine by some colleagues. Next slide, please. Okay, this is a huge one, and I think we touched base a lot on this earlier in regards to mental health, but it is so essential, right? If you get hearing loss, we figure it out, we put, get you a hearing aid, see if we could do this, cochlear stuff. This is more challenging approach, and that's why we appreciate a Cancer Survivor Summit like this, because this is what we want to push in our communities. This is where in the community, through all of the support of the people here and our leadership, can really bring the mental health support to the forefront, that it is not an optional thing for our patients. This is a requirement. This is the bare minimum for our patients and our cancer survivors. So you can see here, mental health challenges like anxiety, 30 to 50%. You know what? Always at the end of a treatment, the parent of a child will always say, oh yeah, we rang the bell, we're excited, it's over, and then here comes a different kind of anxiety. This is now when I'm worried, This is where I'm gonna be really concerned. Is this thing gonna come back? And you think it gets better over time, and maybe it does, but I've even had patients 6-7 years later going, oh my gosh, every time I come to see you, I start to have a panic. And that is the reality of the trauma of cancer treatment. Depression, post-traumatic stress. Also, we look at education and employment struggles. We need individuals that are dedicated to providing resources to our childhood cancer survivors into their schooling, trade schools, colleges, really understanding what these patients need that's going to be different than other types of learning disabilities or other types of problems like ADHD. This is what needs to be the focus in improving employment as well, because then it also affects their ability to launch, right? To launch into adulthood. Many of our patients have delayed independence. Their higher likelihood of living with parents well into adulthood. Financial dependence, really because they're not able to get into that workforce as easily, and then they're really dependent on the people around them, and that's difficult. That's difficult for everyone. We know that childhood cancer is not a cancer of children. It is that of the family. Everybody there, the child, their parents, their grandparents, their community. And so this is where we need to provide mental health support, social workers, all of the counseling that is necessary to support these needs. Next, please. This is something that we in Florida, but also nationally, are really attempting to require for our pediatric programs, pediatric oncology programs. It's called Passport for Care. Has anyone heard of Passport for Care? Yes, Passport for Care. So this is a really important tool to provide patients and their primary care providers the confidence to care for the medical needs of cancer survivors. Right? So you finish up treatment and then you go to the doctor and the doctor tells you, okay, so you had what? Okay, you had leukemia. Okay, all right, great, and you're doing great. Okay, and what medicines do you get? You remember like a couple of the medicines? There was that one with the D and the steroids, those were bad. And it's hard to remember and to really be able to kind of conceive all those things that you received and went through. So it's important that we do that for you. We as oncologists, that is our responsibility. We need to make a cancer treatment summary for you that includes everything that you received so that you can then be empowered to monitor those things appropriately. And I'm just going to show you a quick example and then we'll be done. So next slide, please. So this is what we need to do, this cancer treatment summary. You know, we give your name, your date of birth, the cancer diagnosis, when it was diagnosed, the chemotherapy treatment, if you received it, important things such as the total doses of certain ones. Then we've got radiation. Did you receive it? How much did you receive? Where did you get it? Then also things like stem cell transplant, surgery, etc. So it's very important that you have that. That is your passport, the first part of your passport. Next slide. And then the cool thing about this program is that it's not just like, it's not general. Oh, you got doxorubicin, so you've got to get an echocardiogram. No, it is specific. For example, there's a table like this, okay? Well, if you received, let's see, 300 milligrams per meter squared of this doxorubicin and no radiation, well, that falls into echocardiogram every 2 years. For example. Same thing for hearing, right? Oh, they received cisplatin, carboplatin, or more than 30 gray radiation to the ear. Okay, well, that's your screening requirement. Audiograms, etc. after age 13. It's very, very specific, and it's specified for you as the cancer survivor. Next slide. So what this looks like as a fake here treatment summary is this. It gives you exactly, you know, the diagnosis, maybe they were on a research protocol, it'll specify everything that that patient got. Next. And then you've got the recommended follow-up. So it's really clear, it's saying, okay, cardiovascularly, you're gonna need to get an echocardiogram and it has to be every 2 years. So when you go to your pediatrician, primary care provider, you know, family med doc, and you say, okay, here, this is my passport. This is what tells you to do for me at whatever regular intervals. And it's so much easier because the truth is, in this day and age, most primary care docs are running like crazy to see their patients, and they don't have, you know, the hour to spend to be able to break everything down and find all the information. So the Passport for Care, and I'm really proud of Florida for making this a priority in the care of our children with cancer, to make this a requirement that we as oncologists do this for all of our patients so that they and their physicians are equipped to really monitor for their future. And lastly, I just want to mention one thing. We really are trying to decrease these late effects by decreasing the toxic treatments without sacrificing excellent survival. Hodgkin's is one of those beautiful stories when we look at Hodgkin's lymphoma. You know, we have spared radiation used to be for everyone with Hodgkin's. Now, we hardly give it to patients with Hodgkin's lymphoma. We have reserved it for the very small percentage of the highest risk patients that absolutely need it. And by that, we've decreased the incidence of breast cancer, of pulmonary fibrosis, of cardiac dysfunction. So we need to also, as oncologists, to help our kids as they survive into adulthood, have less things to worry about by also decreasing the toxicities that they're exposed to. So we look forward to the future of treating children with cancer, looking to see them into survivorship, into adulthood, and I love going to high school graduations and all sorts of things in the future to celebrate our kids. So thank you so much for joining us today.
Yeah, I'm here. Okay. Just cut through here real quick, sorry.
Thank you so much for your presentation. Just in recent news, all of the things with vaccines, and since you're talking about school-aged children and cancer, could you give us kind of a rundown of the thought? I mean, we talk about herd immunity, how important that is for kids who are enduring cancer. Just wanted to get your take.
Yeah, no, it's a really important question, and I'll be honest with you, I am stressed. I don't know who else here is stressed, but I'm stressed about that. I have 3 daughters of my own, and all of my patients, I always tell them I'm going to treat you like my kid, which is sometimes tough love. But vaccines are essential to the prevention of infection, disease in our country. You know, we do not want to go backward. We do not want to go backward in this country and in this state, and seeing diseases that killed children, adults, etc. in the past. This is really scary. Herd immunity, let me tell you a conversation I had with my patient yesterday. I've got a little baby, about a month old, who's receiving chemotherapy right now, okay? They're, what is it, month old. Did they get their vaccines yet? No, they can only get it, their Hep B, and then at 2 months, they're able to get their first real set of vaccines. They're worried, right? And so, as a result, they're like, okay, but so what do we got to do? We got to get the grandparents vaccinated. Okay, we got to do this. And they're concerned. They said, how do you think herd immunity is going to be affected? And it is so hard to answer that because we have seen little glimpses of that with people less likely to vaccinate their children. But man, if that really is a thing that becomes real, it is a true scare for our patients who have immunocompromise. And so then the benefit they can't get, my patients cannot get vaccines during their treatment and for 6 months beyond, because their immune system won't mount a response. So it is essential. And one other thing about vaccines also is that if we're not making our kids go to their pediatrician to get their vaccines before they enter school, talk about social determinants of health, you may not get those patients to go to the pediatrician at all that year. Let's think beyond that as well. So thank you. This is an extremely important question, and it's not going to increase your risk. Never has it been shown to increase the risk of cancer, the vaccinations that children receive as children.
Thank you, Dr. Della.
One more? All right. Thank you, everyone. Have a wonderful day.
Hi, I'm Congresswoman Lucy McBath, and I represent Georgia's 6th Congressional District in the metropolitan Atlanta area. I want to thank Congresswoman Wasserman Schultz for bringing us together today and for each and every one of you for being here. I am a 2-time breast cancer survivor myself. I remember receiving the frightening news from my doctors and the mental toll a diagnosis takes. Unfortunately, my husband is also dealing with a recent cancer diagnosis and has faced complications during surgery. As my family navigates these personal challenges, my heart and my support is always with all of you. Improving access to care and making it more affordable is one of my top priorities in Congress, as I know it is for many of my Democratic colleagues in Washington. We have to keep our work to bring awareness about early detection. We've got to continue to do it and secure research funding and care for our health providers. Thank you all for your tireless efforts, and thank you to our loved ones for your support. To those dealing with a diagnosis right now, know that you are not doing so alone. We must keep our faith strong, and we will keep our hope alive, because we need one another for this work. God bless, stay strong, and thank you.
Please welcome back to the stage Congresswoman Debbie Wasserman Schultz, who will moderate the fireside chat discussion, Are we on the cusp of a cancer-free future? How AI and immunology are creating hope for survivors.
Well, it's good to see everyone once again. Hopefully that you have gotten a lot out of the presentations and the Q&A today, and that you're going to leave this summit as we begin to wind down, ready to be able to make sure that you can be stronger in the journey into your own survivorship or that of your loved ones and others that you know. Now it's my privilege to open up a conversation that will truly embody the spirit of the summit, resilience meeting innovation. Our fireside chat today will bring together the voices of survivors, advocates, and scientists, and shows us how lived experience and groundbreaking research can shape the future of cancer care. We know that survivorship is not just about overcoming a diagnosis, it's about preventing recurrence, extending life, and improving the quality of life. Cancer vaccines and AI are some of the most exciting frontiers in that fight. They represent a promise that through science, we can give survivors new tools to keep cancer from returning and perhaps one day prevent it altogether. To explore this powerful connection between personal perseverance and cutting-edge science, we're joined by two remarkable leaders. Kristen Dahlgren, former NBC journalist and a survivor who turned her own journey into action by founding the Cancer Vaccine Coalition. Through her advocacy, she's built a community committed to advancing vaccine research and giving survivors hope that science can safeguard their futures. And we are also joined by Dr. Dwayne Mitchell, a neurosurgery professor at the University of Florida, go Gators, my alma mater, and a nationally recognized leader in translational cancer immunotherapy research. His pioneering work in cancer vaccines opened entirely new avenues for treatment, bridging the gap between laboratory breakthroughs and the patients who need them most. Together, they'll share personal stories of resilience, insights into the science driving vaccine development, and a glimpse of what the future of survivor-centered care could look like. So please join me as they come to the stage in welcoming Kristen Dahlgren and Dr. Dwayne Mitchell. Thank you both so much for being here, for taking your incredibly valuable time and making sure that we can really get some more forward-looking, futuristic dialogue going and talk about the exciting research that both of you I know are aware of or actually generating in the case of Dr. Mitchell. So I'd like us first to have you each tell us briefly about your own work and how it connects to advancing cancer vaccines and emerging tools like AI in the cancer care space. So we'll start with you, Kristen.
Okay. Thank you so much, first of all, for highlighting this and for your question about vaccines earlier. Look, I never thought I would be in this space. I was a journalist. I was working at NBC News. I had my dream job. I had a young daughter. And then on my 47th birthday, I noticed a dent on my breast. I had had a mammogram a few months before that came back clean. And so I was diagnosed with stage 2 breast cancer. I thought that early detection, knowing your body, would be my platform. And then after I shared my story on the Today Show and I went through treatment, a few years later, I was doing some research into cancer vaccines. I had never heard of them. I was a survivor. I was a journalist. I had never heard that cancer vaccines were not just in development, in a lab somewhere, they were actually in clinical trials. And so it was that conversation that changed my life. And what I realized was that, doctors like Dr. Mitchell are doing incredible work and research, but many times they're in silos. So we put together a group of the top vaccine researchers in cancer vaccines from around the country, and we realized that they needed funding. So we started through philanthropy trying to raise money and fund the trials. It became such a big project and such a passion of mine that I ended up leaving my job at NBC and starting Cancer Vaccine Coalition and working on it full time, because this is real. We have the science for cancer vaccines. What I'm trying to do is to get it to all of us sooner. Because, and we'll hear just what's being developed. But if we wait, and if we delay, and if we don't have robust clinical trials, it's going to be decades. And in that time, we are going to lose a lot of people, and that is totally unacceptable. So I'm doing what I can to spread the word.
Thank you so much. Dr. Mitchell?
Thank you for that. Well, first of all, thank you for Congresswoman for organizing this forum and also the opportunity to talk about this topic, and the work that you're doing to support the field is extraordinarily important. My background, I'm a physician scientist, and I have been involved in trying to leverage the immune system and its incredible capacity to fight cancer and turn that into a therapeutic treatment approach. In my case, I focus on brain cancer, both children and adults with malignant brain tumors. And I have been in the field for going on 30 years. In 1995, when I started my PhD work, it was focused on cancer immunology and trying to understand why doesn't the immune system eradicate cancers like it should, it's capable of doing, and how can we educate a patient's own immune system to really recognize tumor cells as a foreign invader and eliminate those tumor cells like it goes after a virally infected cell and eliminates them from the body. And so over the last 20 years or so, I've been involved in translating laboratory discoveries into clinical trials for patients with malignant brain cancer. And we'll talk about, I think, some of the promise, some of the opportunities where I do believe that using the immune system to fight some of these cancers that we currently don't have very good treatments for is on the horizon as being a new way that we can combat really aggressive cancers.
Thank you so much. I know the way I think about vaccines, not being a scientist or a medical expert. Most of us think about them as far as a way to keep you from getting an infection like the flu, or to immunize you against getting a disease that a vaccine was developed for, to stop that disease in its tracks and prevent someone from contracting it. Dr. Mitchell, I get the sense that cancer vaccines are different, and can you explain the difference in the way they work, and where are we right now in terms of making them a standard of care option for patients? Because unlike Kristen, since I've been involved in the fight, I have been very aware, knowing that we're, as a senior appropriator, that we're funneling millions of dollars into that research, yet I haven't seen it really actually in mainstream use yet.
Across the finish line, that's right. So you hit on that when we think of vaccines, really that term was and is developed to prevent an infection like the flu shot. Cancer vaccines you could think of more as a therapeutic. Cancer vaccines would probably be the more accurate full name for it, where we are essentially taking a patient who already has developed cancer but trying to boost their immune recognition of that cancer as something that it should be fighting against. And the immune system has incredible ability to detect differences between cancer cells and normal cells. But one of the challenges is that cancer also sends mixed signals to the body. It's coming from your own cells. There are changes that the immune system can recognize, but it often sends signals of this is an injury that should be repaired rather than a disease that should be fought off by the immune system. And so cancer can unfortunately trick our bodies into supporting the growth of that tumor rather than mounting a fight with the immune system to get rid of it. And so what cancer vaccines are doing, very much like a vaccine, you boost the immunity to try to prevent an infection. In this case, we're trying to boost the immune response to really respond against that cancer like it would against an infection, and either prevent that tumor from returning or eradicating, the disease actually that's still present. We're trying to engender a strong enough immune response to eliminate existing cancer.
But just a follow-up question. So if it's a therapeutic treatment, and that's what we're putting the dollars into in terms of research, that's more individualized than developing a vaccine that someone eventually could receive that would prevent them from getting cancer in the first place, or certain types of cancer.
Yeah, so we do, there are, and it was mentioned a little bit earlier today, there are some vaccines today that prevent you from catching infections that can lead to cancer, like the HPV vaccine or the hepatitis B vaccine in the case of liver cancer. There is actually emerging and exciting research on the prospect of creating more what we would call preventative cancer vaccines, as we've begun to understand some of the changes in cancer cells that may be shared amongst patients. It is at least possible to, and there's ongoing research to think about even being able to prevent some of those cancers by really boosting immunity against the very specific changes that we see within those cancer cells. But right now, the overwhelming majority of research in the field of cancer vaccines is based on, trying to add this type of therapy as either an what we call adjuvant after someone's had surgery to remove as much as possible, chemotherapy or radiation if that's a standard of care, to then integrate boosting their immune response against that cancer. And we can do that in an individualized way once we understand what are the components of that patient's cancer that the immune system can potentially hone in on.
Thank you. Those are important distinctions. Kristen?
Yeah, I was just going to say, I think the distinction, too, between infectious disease vaccines and cancer vaccines is really important to make, especially in this moment. So just focusing on cancer vaccines, these are given to people, for the most part, who have already had cancer or who are undergoing treatment. We're expected to put toxic chemotherapy into our veins. So it's a much different conversation than taking a healthy person and asking them to take a new drug. So that's one thing. The other thing with the development, they've been trying to get cancer vaccines for years and years. We're in this particularly important moment, though, because we have AI, the development. We understand the immune system better. We've seen how during the COVID vaccine, we were able to get robust trials and advanced mRNA science very quickly. So all of those things coming together, and then there are personalized vaccines and also off-the-shelf vaccines in development. AI is helping to look through people's tumors and see what antigens are shared from different people, and then the doctors are able to develop these vaccines that may work across even different cancers. So it's a really exciting time, and we hope that that money that's going into it starts to really yield some exciting results.
Oh, I certainly do too. And Kristen, I want to just have you extend out some of your thoughts about what the future of therapeutic cancer vaccines might look like for cancer patients and survivors, and how could it transform the survivorship journey for an individual who's been through cancer?
Look, so we're about to fund a trial at the University of Washington where patients are given a vaccine before their surgery, so very early on after their first breast cancer diagnosis, and that's to prevent recurrence. So we'll get that data to see whether we can do that. So imagine, I don't know anyone else in the room, but if you're a survivor, you think about recurrence every day. Every headache I get is this something? I mean, that's a terrible way to live. And so the potential of cancer vaccines to take some of that worry away, knowing that your immune system knows what to look for and will fight it. There are also vaccines that we're testing in metastatic patients that can actually eliminate disease even further along in the process. And so I've talked to people. One woman got a vaccine 20 years ago, an off-the-shelf vaccine. She is still alive. She was given a 7% chance of survival. She is still alive, and she is not alone. 85% of the women in that trial who were given that vaccine at the right dose are still alive more than 10 years out. That is not just luck, and we need the trials to continue so we get more and more data and can get this approved.
I mean, that's incredible news about the off-the-shelf product by itself. I have been able to bring home really millions of dollars at this point to our local, to FAU, to FIU, here at NSU for cancer research, but particularly for precision medicine, because we are making advances, and AI is really helping to fuel this in being able to make sure that the patient that walks in off the street with a diagnosis can actually have their own cancer unique to how it's developed in them. There's incredible research that shows amazing results in survival and coming through the other side by targeting that person's tumor specific to its genetic makeup. And so we just need to make sure that we are continuing to use federal dollars, US dollars, to continue that remarkable research. I want to focus on mRNA vaccines. We've heard a lot about mRNA over the last few years. Probably all of us know more than we ever thought we would know. I never heard of mRNA before COVID, and didn't know that it was something that went far beyond the idea of using it to prevent COVID. I've personally pushed for more significant investment in mRNA research for vaccines through my appropriations work, but I'd like both of you to talk about the promise of mRNA vaccines to prevent cancer or stop it from coming back. And are mRNA vaccines different from other types of vaccines that are being researched?
I'll let you take the science first.
Sure.
Good call.
No, great question. Most people, as you mentioned, have become familiar with mRNA vaccines because of the COVID pandemic and the COVID vaccines, but actually a work using mRNA to boost the immune system actually was developed initially for cancer. Our laboratory started looking at mRNA-based cancer therapeutics in 1999. Our first clinical trial in patients with glioblastoma using an mRNA-based immune treatment approach, my first started in 2006. So this has been an evolving field, and one of the reasons we were so rapidly able to mobilize that during the pandemic was because there had been years of research understanding that mRNA as a vaccine or as a boost for the immune system. Think of mRNA as just a messenger. The M actually stands for messenger, and it just instructs the immune system what to home in on. And it can do that very effectively. The other advantage of it is it can rapidly manufacture this, rapidly scale it, and you can actually change it quite rapidly as well. It's a very easy molecule, if you will, to change the instructions that are being given to the immune system. So in the case of cancer, if you think of cancer evolving over time, it's actually possible to make a personalized therapy directed against a patient's own cancer in a matter of a few weeks. We have ongoing clinical trials at University of Florida in patients, pediatric patients with brain cancer, adults with glioblastoma, several other cancers as well, where within weeks after the patient has undergone surgery or biopsy, they've made a mRNA-based personalized therapy that's directed against that patient's own cancer. And so this is something that has incredible potential to not just boost the immune response against that patient's tumor, but we are already envisioning the possibility of following that patient's immune response, and if that cancer returns, rapidly being able to manufacture a new vaccine that takes care of the cells that the first treatment did not. So it's been a long, I say it's been 20-something years for an overnight success in terms of what people think about. But I think it just is a tremendous potential in the therapeutic arena.
It's incredibly exciting. Kristen?
Yeah, and I mean, take that in for a second. A vaccine for glioblastoma, which was really considered a death sentence for such a long time, and now we're seeing incredible results in that. Pancreatic cancer as well. I mean, some of the most difficult cancers. And I'm always struck by when I first started this in 2023, they said, Kristen, don't say cure, don't say cure. We were on a call and I heard you say cure. And so I think the promise and hope is really changing, that we do have some tools, and mRNA is one of them. There are DNA vaccines, there are dendritic cell vaccines. We don't know exactly what it's going to look like, but we need to do the research. And I'll just say, in countries like in the UK, they're giving out 10,000 cancer vaccines as part of clinical trials, widespread, robust trials to get the data quickly like we did during COVID. And that's how you move things along. We're not seeing that here yet. It's your lab doing research. It's someone else doing another study of 60 patients. And that's all great. But if we could move that faster and tell whether these vaccines are better than the current standard of care, most of which were developed in the 1800s, mastectomy and radiation and chemotherapy from, I think, the 1940s. This is 2025. We have incredible science and we have tools that we can use. And so leaning into that and making sure that people understand canceling mRNA research affects mRNA research for cancer. And so we need to keep our foot on the gas. We did hear the head of the NIH saying that cancer vaccines are very promising with mRNA. We'll continue that research. You know, we need to make sure that our government does that.
And we thank you so much for making that point. It is both of you. What deeply concerns me is that the politics surrounding just mRNA in an umbrella way could short-circuit the incredibly important research funding that will result in us being able to save more people's lives, to ensure that we have more survivors, to ensure that the effects of the way we treat cancer are, improved and less impactful physically. That's why I asked the question about the difference between mRNA is an umbrella. And I partially asked a question that I kind of knew some of the answer to. mRNA is an umbrella of the types of vaccines that fall under it. We have to make sure that we continue all of the research funding, not just for this type of mRNA vaccines. And I will just add that we absolutely have to make sure that normal run-of-the-mill vaccinations continue to be required in the state of Florida and in this country. There are a lot of people that I spoke to even here today who have an immunosuppression and are at risk. The more people we put out into the public sphere who have not been vaccinated, the more people that we're going to put in jeopardy. Okay, that's my political statement for the day.
And this is nonpartisan. I mean, cancer doesn't care which way you vote.
No, and I started, you weren't here for my opening remarks, but that's exactly what I said in my opening remarks. Cancer does not care whether you're a Republican or a Democrat, and quite frankly, any disease doesn't. And I want everybody to be able to make sure that they can be as healthy as possible. And if we can relieve someone from the burden of cancer and relieve families from the horror of losing a loved one, then I'll just continue to use every ounce of strength and power my platform provides to help ensure that can continue. Thank you. All right, that's as political as I'm going to get for the day, but the vaccine thing really sets me off. Sorry. Sorry, not sorry. So no two cancers are exactly the same, even if they start in the same part of the body, and that's not something that the average person realizes. And every person's immune system is unique. That's something that we've learned more and more as time has gone by and as research has shown us. So Dr. Mitchell, what are some of the developments in AI and cancer immunotherapy that you find most promising right now, and which ones could have, and you notice the direction my questions are going, the most near-term impact on patient outcomes?
Yeah, fantastic question. And one of the things to realize with research is that, everything builds on the history of great work that's been done and been funded and supported. And we've gained an incredible understanding about the biology of cancer, but that also has led to an understanding that it is extraordinarily complex. And like you mentioned, even two patients with the exact same diagnosis, take glioblastoma that is studied, their tumors are completely different from one another. They have individual biology that's specific to that patient. And right now, the way we treat patients, for the most part, is everyone gets pretty much the same type of therapy. We've gotten better and better as we can understand some of the complexity to individualize that treatment. But we really, without AI, the ability to really contextualize individual complexity of both a patient's cancer as well as the individual nature of their own immune systems, AI gives us the capacity to take that complexity and digest it down to patterns that we can start to understand and individualized therapies that we can provide for those patients. So one of the areas that's really exciting, and it's work that we're already ongoing is, and Kristen mentioned this, is that while every patient's tumor is unique, we can start to identify commonalities between what are things within different cancers that a patient's immune system can recognize. And by analyzing hundreds of patients or thousands of patients with this data in AI, we can begin to see that there are some common targets that we can go after and start making individualized, but starting with an off-the-shelf, say, cancer vaccine for pancreatic cancer or glioblastoma, and then adapt it to be personalized as you learn more about that patient's own tumor. So AI is allowing us to get a handle around this complexity. It's allowing us to actually predict who's more likely to respond to certain types of therapies compared to others. And so in the very near future, you'll see the capacity to, maybe in a clinical trial setting, use AI to say, this is the type of trial that we believe would be most beneficial for you based on the analysis of your biology and immune system. And somebody else with the same diagnosis, we can now say, well, you know what, based on the patterns that AI has taught us about your disease, you will most likely benefit from a different type of treatment pathway. And so there's a lot of avenues where the tremendous information that we've gained through years and really decades of research is now being able to, it's almost like think of it as a huge jigsaw puzzle that AI is allowing us now to put together into a much clearer picture of what's going on with the patient's immune system and their cancer, and now tailor that therapy to be much more effective.
And not to put pressure on you, but do you have a sense of how near term that is?
Yes, so a sense.
I know how to answer the question in a softer way.
Well, as you know, AI is moving so quickly. The advances are literally, almost week to week, certainly month to month, tremendous advances in the field. In terms of using AI to drive, let's say, the nearest term wins are probably going to be, and we're already seeing this, in diagnosis, being able to, we can use AI to see patterns in MRI images that we honestly can't see with our own eyes and get early predictions of, tumor recurrence long before maybe we would have normally picked it up. So I think diagnosis and early detection is going to be the nearest term fruits of AI, and I think there are trials validating that ongoing now. We may see that in the coming year to 2 years.
Yeah, we've seen some news that says that, in no offense to our radiological oncologists, but that AI in at least some cases has been better at diagnosing a cancer than the actual human radiologist has.
Correct. And I think what we already are experiencing that, and will increasingly experience what we will call AI-assisted diagnosis and care for prevention, detection. I think for therapeutics and coming up with new treatments or individualized treatment care, we have a target of bringing our first, sort of AI-developed cancer vaccine into the clinic within 12 to 18 months. Now, this will be clinical trials.
Right.
But that is a goal and is actively being worked on, and I think that's a realistic target that we would be in clinical testing of the concept of a vaccine formulation that AI has helped develop.
Incredibly exciting. Kristen?
Yeah, and to give people hope, we have a doctor who works with Merck, and they're in a phase 3 trial for melanoma vaccine and could be on the market for people to use by 2027. So this is real, it's happening, and I think AI is only going to move the science faster. And think about it, like, if the government were to take a more active role in this, a national tumor registry where we could have everybody's tumor and we could be using AI on a grand scale and supercomputing to tell where are those patterns, where are those things. There's so many things we can do to move this quicker, but it's going to take funding and who has more than the U.S. government for this.
Exactly. Well, I really look forward to continuing the work that we were able to do together, both in terms of my role, which is trying to advance legislation, to put frameworks around your ability to advance the fight against cancer, bring funding to bear so that we can ensure that you can make those investments and advance the research, and of course ensure that we all work together as advocates, because advocacy is incredibly important. And Kristen, I know you're on the Hill all the time. Look forward to seeing you again up there soon, maybe as soon as next week. And I just, we're incredibly behind because we wanted to make sure that these were robust and substantive conversations. So I want to thank both Kristen and Dr. Mitchell for being part of our panel discussion, and look forward to, stay tuned as we're going to bring our keynote speaker up on the platform. Thank you so much. Oh, you're welcome. Okay, it is now my honor to welcome someone for whom I have the deepest admiration. Many of you know that Bill Zito is the president and general manager of the Florida Panthers, the man who helped transform the team into back-to-back championship organization. And we are all proud Panther fans down here in South Florida. But what defines Bill most is he's not just about the wins or the trophies. It's the way he uses his platform to shine a light on the most difficult battle that any family can face, the fight against cancer. For Bill, this fight has been deeply personal. He and his wife, Julie, know the pain, the uncertainty, and the quiet exhaustion of being caregivers. They know the toll cancer takes, not just on the patient, but on loved ones who sit at their side, who hold their hand through treatments, and the family and friends who carry the weight of worry day after day. Those unsung moments of courage and struggle, often invisible to the outside world, are where Bill's compassion and resilience are forged. And he's taken that deeply personal journey and transformed it into advocacy. Along with Julie, he launched Panthers on the Prowl, Statues for a Cause. In partnership with the American Cancer Society, it's an effort that's filled our community with striking symbols of hope and resilience. These life-size Panther statues that are scattered across South Florida are more than art, they are a call to action. They raise awareness, spark conversation, and most importantly, generate real funding to fuel research and provide critical support to patients and families. It's difficult to overstate our gratitude for what Bill and Julie have given to the cancer community. They show us that leadership is not only measured by amazing professional success, but also by the courage to step forward, share your story, and commit your time and energy to lifting others up. Because for Bill and all of us here, this cancer fight is not just a professional cause, it's a personal one. And when leaders like Bill Zito use their voice, as I've told him, their influence and their platform, they remind us that none of us are in this fight alone. So today, as we continue our mission to eradicate cancer as we know it, it is my privilege to welcome not just a championship general manager, but an advocate, a caregiver, and a voice for hope. Please join me in giving a warm welcome to the leader of the back-to-back Stanley Cup champions, Florida Panthers GM and President, Bill Zito. Thank you so much.
I come bearing props. Thank you, Debbie. Thank you all. Sorry. Okay. When I was asked to come today and to speak, I was very reluctant. It's difficult for me as a non-survivor, as a non-patient, to stand in front of people and talk about what I'd say our journey is, our family, through the shared experience of my wife Julie and her mom Pat, my sister Maggie, my mom, my dad, who's still with us, and frequently for example, a news outlet might come and say, "Oh, tell your story." I don't have a story. I'm okay. And it's hard. It's hard to talk to a room full of survivors and experts and caregivers and feel like I even have a right to do so. And as I share with you some of our story, I will share with you my why and how important it is for all of us to get over themselves and understand that this is a collective fight for everybody so that we can fund, hi Dr. Kelf, that we can fund the research, that we can fund the medicine, and hopefully sort of through a quilt of experiences and stories, we can share our story with you and encourage everybody here to do a little bit more and to pull others into the fight and into the struggle, to be proactive, to do whatever you can. Everyday tasks are the ones that are important. So that's where we're headed with this. I'll explain the Panther as well in a moment, and my Joe DiMaggio sneakers. So, well, they'll be for sale on the internet in short order. I also want everybody here to take note of Gabriella. And Gabriella, probably nobody here knows. Does anyone know Gabriella? It's very specific. Probably this week, all of you, everybody, will be aware. Well, some may know Gabriella better than others, but hold that thought. Our family journey and fight against this insidious disease actually began with my mother when she was 5. She lost her father, my dad's parents, and in a very real way, first person for our family was in 1995. My sister Maggie was pregnant, and she was diagnosed with Hodgkin's. She took the baby to term. She had significant radiation and moved forward. And she knew she was going to have some health complications. In fact, I know she was an older young adult, but the earlier presentation from Joe D was like, oh yeah, she did have a lot of complications. Some were directly related to the radiation that were obvious, and then some other health issues, but she did pretty well until, well, I'll get to that point. In 2010, Julie and I are married. Pat's mom, she's diagnosed with leukemia with AML. Okay, we start going through that battle. And really, Julie took it on herself. She was really the primary caregiver for Pat, and I don't know, she spent 200 nights maybe in the hospital downtown in Chicago. We lived in the suburbs, and we had our twin girls in 2011. So through this process, she's managing twins. Our house was a circus act. If we should have had a reality TV show. And then she'd go down, spend the night with her mom, make sure everything was there. And really, that was the first taste we had of the importance of the caregiver and advocacy and understanding, listening to what the process is, taking notes, educating yourself, having the courage with respect to question and interact with the doctors because they're human too. Indeed, Julie at one point saved her mother's life. She was in stem cell therapy and was home. Something happened. She was rushed to a different hospital, and I don't know exactly all of the specifics of it, but perhaps they were going to give her platelets or something like that, which would have killed her given the therapy she was receiving from the stem cells. I'm not sure. It was platelets, whatever it was. And the doc said, we didn't know. How would we know? But it was through the process of advocacy for her mother that she was aware, I need to share this information. And then it dawned on us how important it was. In the course of that experience with Pat, it dawned upon us as well how important little things that we do every day, daily tasks to help others, can be in the fight. There was a Starbucks in the hospital in Chicago in the lobby. It opened at 5 a.m. So if we did the night shift, we'd go at 5, obviously to get coffee. There's a guy we saw there a lot. You a doctor? No, my kid's here. He lived in the hospital lobby. So immediately, the Ronald McDonald experience resonated through us. Like, okay, we got to do something. We have to help. And that started the process of understanding how important it is to use our position, in my situation, to use all of the gifts and blessings of the hockey world or the sports world to try to move the needle. So Pat's undergoing treatment, the twins are born, and we lost Pat in 2012. 2013, our son was born. Pat never met him. 2014, my mom was diagnosed with pancreatic cancer. Early detection. Her back hurt, and she went in, and the orthopedist had a new technician in the rotation who was actually being trained. That person had been on pancreatic cancer the week before. He said, I think your back's okay, but you got a dot in your pancreas. What? Yeah, you better have it checked out. And she did. So she basically was at stage 0 to the extent that exists. And she lived for 7 years with pancreatic cancer because of early detection. And I have to believe that today it would even be longer. Remember Gabriella in the context of diagnosis. So my sister Maggie I'm sorry, I skipped one. 2011, Maggie had neuroendocrine cancer of her pancreas. So she had the Whipple. And then fast forward to 2014 when my mom's diagnosed pancreatic, same doctor, same Whipple. And at this point, we're pretty familiar with the procedures, the ins and outs of the pancreatic process, and life goes on. We battle, and we support my mom and my sister. In 2019, in January, we lost my sister, Maggie. In between her neuroendocrine and us losing her, she had breast cancer. So she had 3 cancers. It's a little bit of a more involved story, but we lost her in January of 2019. May of 2019, I'm the assistant general manager in Columbus, Ohio. And so that would be like the number 2 person in the sports organization. I'm in Seattle, Washington, interviewing for a job, and I'm going to get it. It's a brand new team, dream job, oh my God. Come home, it was Mother's Day weekend. Julie says, I've been diagnosed with breast cancer. Okay? My mom's in town. She's like, losing it. My pancreatic cancer's back, same weekend. So we were in one immediately. And I guess I freaked out, but Julie didn't, and my mom didn't, and they just kept plugging along. It was hard. It was hard for our kids as caregivers. We didn't want to get help, but we knew we needed it. But we didn't want to have a stranger, perhaps, around our kids with them getting information from someone they don't really know. So Julie was her own caregiver. Based upon all of her experiences and what she knew, she was pretty much coaching me and successfully beat BRCA and is doing great and is sitting with Dr. Kalf in the front row. So then we lost my mother in 2022. I say this not cavalierly, but the timeline isn't as important as my why and the importance of the early detection. Certainly it gave my mom a reasonable quality of life for a long, long time, and she stayed with us. She got to know her grandkids. It helped Julie survive and beat cancer, and It's something I think we can't take for granted. You all know that. I'm not teaching anybody here anything new, but it's important, I think, that we are proactive, that we fight the fight, and we spread the word. And I tie that back into, why am I talking to you guys? I'm happy to talk about hockey all day long, but what expertise what can I share with you that you don't already know? And that's, I guess in tandem, it's practicality, experience, and probably just love. How does that, how do you, like, that's what's driving it. That's what people in the hospital, when you understand, I don't have to elaborate on that. After the experience with the gentleman at the Starbucks, when Julie was in chemotherapy, there was a doctor named Miriam Lusberg. And in Columbus, Ohio, the James is the sort of the Sylvester of Ohio State. And they have a pretty famous bicycle ride called the Pelotonia. And I think it's the largest single fundraising event, maybe in the world, in one day. It's a bike ride, and you can ride like 20 miles, 50 miles, or 100 miles. I didn't know that. And Dr. Lusberg said, well, you work in sports. I do. Are you going to ride in the bike, in the bike ride? Yeah, no. And she's like, oh, come on. And you would raise awareness. I'm like, I'll buy TV time. I'll write a check. I don't own a bike. I weigh about 250 pounds. I haven't ridden a bike in 30 years. It ain't going to happen. So she said, she goes, well, you could buy a bike. And I'm like, yeah, I could, but like, I just write the check. Like, leave me alone. And she's like, well, why couldn't you do it? She kept pestering me. And, well, I would be injured, literally. I could not, I would like suffer injury. She goes, well, you could get off and walk. I said, yeah, but I'd still be injured. She said, would it hurt? There's kids here, so I won't say what I said to her. Like, it was like emotional terrorism. So I'm like, well, what are we talking? Like, what is this? She goes, well, you could ride 20 miles. That's all you have to do. I said, listen. And then people will donate. If you finish the task, we pledge this amount of money. No, my friends, they want to see Christians getting eaten by lions. They're not going to 20 miles. They're not paying. She goes, well, you could do 100. What? Yeah, no, like, so, again, she says, well, the worst thing that can happen is it hurts a little bit. You go to the doctor. We have doctors. So I said, well, how much are we talking? Like, what? She goes, well, and then it can be whatever you want. I said, well, what's the most anyone ever raised? She said, I know the guy. It's $125,000. I said, oh, boy. Well, and she was so persistent, she got me to agree to do it. And I said, okay, I'm going to do it, and I'm going to break the record. But if I do, you're going to match. What? No, I said, Doc, you get paid? No, and it was more of a fun. I said, okay, when is it? 4 weeks. So by hook and by crook, and I went to our strength coach, I went to the doctor, I went to the bicycle pros, and started to learn about community and love and help. And I had so many people help me. I swear, true story, I finished 100 miles. It hurt for like a day, but like I did it. And I didn't walk any of it, and it was very doable, and it was something like, for anyone who's ever rode, like probably anyone here who's bicycled 100 miles is a bike rider, so they know. I don't know anybody else. I haven't met anyone who went in cold and did it. But I have met people who went in cold and ran a marathon, and they got through. So it's kind of the same thing, but that process led me to understanding the importance of awareness in tandem with the fundraising. We had the captain of our team in Columbus is a gentleman named Nick Foligno, who lost his mom to breast cancer, who is now the captain of the Chicago Blackhawks, a dear friend, wonderful, wonderful human. who had given $1 million to the Children's Hospital in Boston. And he said, you just can't tell anyone. And the fundraisers there said, no, we have to. No, I don't want anyone to know. And they said, if you let us do it, we'll double the donation because people will respond and the word will get out. And we need that. And put your concerns about notoriety or you're doing it. No one cares. This is a fight. We have to do this. We have to raise the money. And we have to get it to doctors and researchers who actually can do something. So he did. And then he encouraged me to do it. And I mean, we shattered the record. It wasn't even close. And it was like literally 4 weeks. As soon as people found out about it, they wanted to help. They wanted to contribute. It was also fun. It was a little selfish. Now I got 4 weeks. I'm going to be in pretty good shape, or as good a shape as I can be in. And so there's all of these emotions and human traits at play, but all for the greater good. And one of the most telling instances, I guess really of love, in this particular bicycle race, it was through the Ohio countryside. And think of the painting American Gothic. And Farmer Brown's out there, I can't say it, it's hard to talk about, with his wife with a sign, she's here because of you. No, not me, for everybody me. So he stood all day. It's like 12, like the first guy's done in an hour and he's like, yeah, I'm super bike man. And then the last guy is like, yeah, he's on life support, I don't know. He stood all day. And it's legion through anybody associated with that this gentleman stays there every year. Farmer Brown's out there with his sign. And poor wife, she's got him like, I'm sick, I want to go. But no, he did it. And it probably says it all about the communal fundraising, the care, the effort, the selflessness. We can break it down and say the guy stood with some paper in the air. But what he did and his impact. If you ever have occasion to talk to people who rode in that race, they'll all tell you about Farmer Brown. It's really, really a moving, touching situation. So, moving forward, Julie's sick. She's doing her chemo. She's upstairs. I'm the caregiver-ish with support from all kinds of folks. I go to the basement of my house where my seven-year-old twin girls are playing, this one's hard, cutting the hair off their Barbies. Guys, what are you doing? You know. Sure you don't want to talk about hockey? Making a wig for mom. So, in that instance of horror, love, pride, I got good kids. These are wonderful kids. No. Like, it was almost as if it was a magic spell that was cast, that in the same instance of fear, horror, sadness, pride, the bigger picture becomes so clear. And how easy it is to push ourselves to move forward, to do whatever we can to help the cause, to stay in the fight, to be proactive. And then in this instance, to think about the caregivers. And there's a couple of levels of caregiver. Obviously the professionals who are saints, who do it every single day. But I think about my father, and I think about, he's 87, and if you ask me, what do you do? Well, what'd you do in your life and your career from 2010 to 2022? Well, I ran sports teams. What'd you do? I was a congressman. I was a baker. What'd you do, sir? I watched my wife and daughter die for 12 years. Every day. Yeah. I went to the hospital every single day. One of them had chemo, one of them had radiation, someone had treatment. I had to do this. I was a caregiver for 12 years. But who thinks about him? He lost his soul. And if anyone's recording this, please don't post that in case he sees it. Like, I don't want to be mean to my dad. But he lost a part of his soul. And I'm ashamed that in the moment, having been through what we were through, and I love my dad, I'm very close with him, I didn't think about it. There's, hey, Dad, how you doing? Are you tired? Oh, I'll take a shift. But I never sat with him and talked about what he was going through. I never thought, because I was so worried about my mom or my sister or Julie. And as I contemplated coming here today, that was a message that I think I wanted to share and to implore people. It's really just a consideration. It's just a thought. For those people who are sick, whoever's taking care of you, just ask them. And for those of you who have a shared caregiving experience, be aware, right? Just ask. That's it. That might be enough. So as I kind of apply this journey and story and stories to this summit today, I think about the life after diagnosis. And I think having listened to a couple of the previous presentations, some of this is just lost and probably wasting your time when we talk about advocacy and day one, when your loved one is diagnosed, and the process and the questions and we joke about our internet medical degree, where immediately, boom, you're on, and now we're going to learn about BRCA, and I didn't know who's BRCA. Right? You don't know. And so you're researching, and then the next day you show up and the poor doctor's like looking at you went on the internet, didn't you? Yeah. Oh boy. Okay, well, I am a doctor and I do this, but how important it was to balance getting information with the reality of modern medicine and technology and the human side of caregiving from the doctors and nurses. So that, to me, that process and going through it had been a familiar existence for Julie through her mom and through my sister and mom. But that first time going into the chemo facility with Jules was beyond awkward. And it was sort of that situation where you've kind of been through this. It's not that big of a deal. Get past it, because it's about healing, it's about curing, it's about fighting, not about you feeling awkward. But that was something that it still resonates with me as to why was that stigma attached. And certainly I had emotionally and intellectually dismissed it in my own head, but it still happened. It's almost like when I almost cried telling the sad stories or the bittersweet stories. Why does that happen? I don't know. But I do think it's important, because we need to get people past that, and we need to prepare people so that they can help, so that they can get themselves to the next level. We had a story that we used to call how many people here have gotten the frozen lasagnas from the neighbors and family? Everyone, right? And you went to Costco and got the big freezer because you had so many. And we had one where the neighbor came over and the kids were eating the lasagna, and she had brought, it sucked. It was so bad. And so yeah, we're not eating this. And no, we're not. So we had another lasagna, right? But she had brought a vegetarian, white sauce, and the kids were eating one with the sausage and the red sauce. She came by, she said, how's the lasagna? Oh, thank you so much, it's so good. And she looked and she goes, no, that's not the one I brought. Oh, really? No, you brought this one. So the levity in the moment in the situation of understanding it's got nothing to do with lasagna, right? Allow these people, allow loved ones and friends to help. Allow them for their own good. It's an act of graciousness to allow people to try to help. And you just throw out the lasagna, it's fine. But let people help. Let them in, let them feel, let them express their love for you, because it all circles back. The healthier caregiver, the healthier community around the patient, this is medical, right? Is going to be a more successful fight against the disease. Having a plan. So we were very, very fortunate, having gone through the experiences of our family members. Julie had it almost scheduled. It's like, oh, time to do this, time to do that. Okay, great, no problem. And even post-treatment, we knew the temporal scope of the chemo. We knew when and how the radiation might happen. Julie chose to get the double mastectomy. We didn't have even though it was a short time ago, I think that the evolution in genetic testing has been significantly improved. So we didn't have as vast an offering of genetic testing moving forward. We have 2 14-year-old twin girls. This is a mission of course, of love, but this is for everybody. This is so important. And the experience allows us to appreciate all of these, listening to the talks, all of the developments in medicine. What you, the collective doctors and healthcare providers, can do if we get you money. We can do a lot. We can save a life. And it's kind of self-serving and you feel good about it, but it's true. And that's okay. That's okay. So, sorry. I needn't talk about all of the post-diagnosis services that are offered and the importance of if maybe you have limited resources and aren't able to fundraise. You could give someone a ride to the hospital. You could help them organize their affairs. I mean, even you can send them, a couple cards for pizzas and dinners. You can just help. There's ways to help that actually lead to successful battles. And I don't think we do enough community-wise in imparting this message to everybody. And certainly people who have not been through this process learn it very quickly. And I think that just having resources of people who've gone through this certainly helped us, whether it was our own experiences or other friends we had. We had the red carpet of treatment. The head of the James Cancer Hospital lived across the street. And we had been there about 4 or 5 years, Dr. Chakravarti. We'd never met him. And he came over and knocked on the door. And I'm like, I don't even know this guy. Like, in 5 years, you live across the street. Like, I knew who he was, except we never took the time. And he said, I cannot, in good faith, go to sleep without introducing myself to you. And just offering my help. How important. One act of kindness. How can I help you? So, when I machinate on all things caregiving with regard to today, simple tasks, right? And they're elegant. They're just kindness. Can I do anything? Well, no, we're pretty good. But it is incumbent upon us to not only do them ourselves, but to try to encourage others to do them and to do, nothing needs to be extraordinary. Simple tasks by simple people probably are what's going to end cancer. Sorry, Dr. Kalfa. I'm sure there's some extraordinary stuff you got going, but I'm going to stick with the kindness and the so. But it's true. And so along that vein is Kiki the Panther. And I brought the Panther here today because the ACS had asked us to be, the chairman of their campaign for the year, which I think in medical research and cancer fundraising, that means have a party and hit up your friends. And we didn't want to do it. So Julie had the idea for anybody who had occasion to know about the Cows on Parade in Chicago about 20 years ago, where they had life-size cows on Michigan Avenue. It was an art exhibit, and outside Tiffany, it was Tiffany blue with a diamond necklace, and the Nike store had a Michael Jordan cow, but they're legit. It was so successful and so interesting and so moving that it became its own thing. And it became a source of tourism for Chicago just so people could see the cows. And so living there at the time, it was wonderful. You'd walk down the street and they'd swap them out and people would do new ones. Like, look at this creativity. Look at this talent. Who has the vision to even think about this? So someone had gifted us a couple of these life-size little panther statues, and Julie said, I got it. We're going to do a Cows on the Parade copycat-ish movement where we're going to sell these panthers, and people can personalize them any way they see fit. Maybe for someone it's poignant. That's in honor of my mom and her battle. Maybe it's silly and fun. I made a mahi fish because I like to go fishing. Okay, and that one's glow in the dark too. Maybe it's commercial. Like, no one really cares. Like, United Airlines wants to make an airplane panther. Great, go, do it. But what it does is it can bring people together. It can be fun. It can have levity. It can be light. It can, in the midst of all of the horror, be something nice. Be bright. It kind of reminds me a little bit of that same feeling when you talk about a caregiver. I'll just say a husband, and I'll be a little sexist here with my remarks, but could be a wife too, right? You love to golf. You want to go golfing? No, I'm not leaving their side. You literally have to have a life, or you will not be of service to your loved one, right? So in this case, like, it could be anything. It's okay. It's okay to smile. It's okay to be happy. It's a battle. It's a fight. It's a war. And I think that's really, really important. So we started this campaign, effort, sales pitch, art exhibit, marketing thing. I don't know what it is, but I cannot tell you the level of joy, humility, excitement, passion, awe. And I've only seen like 40 or 50 of them. And we're going to sell 100, and 200, and we're going to raise $1 million. But in the context of that, even more care came forward. Our friend Romero Brito, who I tried to sell a panther to, said, I'll do one better. I'll do one, and you can auction it. Oh, good idea. So now we have a number of celebrities and sort of people for whom we think their auction item will yield money helping. And it's just another idea that was just born out of kindness from someone else. So that's why my panther Kiki here. Kiki is named after our dear friend that we lost during the playoffs. It must have been June. A fisherman from the Keys. We met him 2 years ago, and we had never been to the Keys. And we met him. He took us fishing. We became enthralled with the sport, everything about it, and became very close to him. And then he was diagnosed with pancreatic cancer. And he had never been to a hockey game and became an Uber fan. Unfortunately, he didn't see us win it this year, but last year he did. And we brought the Stanley Cup to him. He's a wonderful guy. We also donated 10 Panthers to current survivors who are either survivors or battling, and they can decorate and personalize that panther on their own. To me, it circles back to the same ideology behind the caregiving and the focus on the big fight, because it is a fight. And part of this is some of the themes that are running through here today: early detection, gap in care. So when you think about early detection, how many people could have been diagnosed earlier and didn't? How many people, and I'm not talking about solely people who may have lesser means and for whom it's difficult. I'm talking about probably some doctors. Have you had your PSA? Have you been screened? Yeah, next time. Yeah. Do you have that time? And it made me think about Gabriella. No one? Still no one? Okay. Gabrielle might come to get you. She might take your house. She might kill you. I don't know. But you will all know if Gabriella comes. And you'll hear about it. It'll be on the news for sure. Probably in the next week. And if I told you, well, are you going to get ready for this? Because she's coming to get you. Yeah, what do I have to do? Well, probably going to take 2 or 3 hours if everybody does it at the same time. It's a little bit of time. You got to go to call. You got to get water. You have to get radios, batteries. Gabrielle is right now a thunderstorm in Africa. Okay? And maybe it will develop into an invest, and then it'll develop into possibly a tropical storm, and then maybe a hurricane, and maybe it'll hit Florida. But as soon as it becomes tangible, we're getting ready, okay? 100%. People we're loading up on water. We're preparing because it might come. The cancer is coming. It's not a question. It's coming for sure. And all you have to just go get the test. I got something else to do. And I thought about even that in the context of, I don't want to jinx us, maybe let's call it COVID-2. In a year it's coming. For sure. And it's going to cause this impact, and we know. Would you donate? Would you help? Would you be part of that fight? Of course, everybody would, right? But then why are we handcuffing ourselves? Why are we sitting down? Why is there not a greater call to action to fight this fight? We know the enemy. The enemy's here. The enemy's coming. And we're not being proactive. So, not scolding, I would hope to suggest and very humbly ask people to think about Gabriella, because if somebody said, if you can help funding, we'll steer it north. You do it. And I think all of our efforts, and actually all of this community, it's almost as if we're working against ourselves, because you try so hard, and cancer affects so many people, it almost loses significance in the day-to-day, and it can't. And so that's why Kiki the Panther exists, and that's why I'm here today. And bless all of you for all of your roles, because you're here because you care. And thank you very much. And get a panther.
Thank you so much, Bill, really, for putting your personal story, your family's experiences, and really sharing the deepest impact that families experience, like yours, when it comes to a very close loved one being diagnosed with cancer. Listening to you, I relived so much of what I've been through when my grandmother in 1990 was diagnosed with lung cancer, and I was, just out of college, and I started to think about, in terms of Gabriella, my grandmother was gone in a year and a half from lung cancer. She made it to my wedding, but several months after that, we lost her. And then fast forward to 2008, and my own mother was diagnosed with lung cancer. And because of medical research, because of progress, because of investment, because of the kind of support that she was able to have around her, and because she was able to have health insurance and could go to the doctor when she was sick and not have to wait, she lived 16 years and got to know her grandchildren and saw them through. You can applaud for that, because I was very happy to have my mother for 16 more years. And we knew we would lose her at the end of the day. She knew that lung cancer would end her life, but she was able to have a full life thanks to the investments and the scientific research and the advancements that were completely different in the 25 or so years that spanned between my grandmother's diagnosis and my mom's. And making sure that we can have not just longer survival, but eradicate cancer and ensure that that people can catch it early, that we think about how we would prepare immediately as we experience, hopefully not, the onset of Gabriella. No one would consider living in our community about not making sure that you prepared for a storm that you knew was going to hit you or come near you and you were going to feel those impacts. And because too often, so many of us, particularly women, think about everybody else in our life except our own well-being. And we're worried about making sure that our children and our spouses and our significant others and our families and our aunties and grandmas and the people who are chosen family, let's make sure that we care for all of the others, and we're last. I'm here to tell you, don't put yourself last. Make sure that you know what you normally feel like so that you know when something feels different. And I want to thank everybody who helped make this day possible. This was an incredibly special gathering, one that wasn't possible without the incredible people of Nova Southeastern University. The entire NSU family is always so supportive of us. It wouldn't have been possible without all of your support coming here today, devoting your most precious resource, which is not your money, it's your time. And ensuring that cancer survivors can navigate their journey requires bipartisan, or really nonpartisan cooperation and long-term commitment. Our mission is to eradicate this deadly disease once and for all. But I know until that day comes, we have to focus on building a strong foundation for patients so that when treatment ends, their path forward is clearer, healthier, and more hopeful. And that's exactly what we've been able to do here today. We heard about the really toxic impacts that result from pediatric cancer. And we heard about the hope that there is from vaccines, vaccines that are both therapeutic and then hopefully one day preventative. This summit and the policy proposals that we advance from it are collaborative endeavors. They're designed to serve all survivors, their families, and the communities that lift them up. And I want to honor my own caregiving family. I can tell you that I would not have gotten through my own cancer experience without my girlfriends, my mom, my husband. My children were not aware of what I was going through, but just the joy that I experienced being able to just be their mom as I went through that with nothing else that I was focusing on in that moment was so critical for me. and making sure that we had a caregiver like Bill, someone who was looking through a completely different lens but was just as impacted, was important for us to have as our keynote. So often all the focus is on the patient of gatherings like this and making sure that we take care of the community that is built around ensuring that someone can get through cancer successfully is critical. One important way that I hope that we can do that is through passage of my legislation, the Comprehensive Cancer Survivorship Act. It is legislation that would help ensure that survivors are never lost in that transition, but instead have the resources and the care and the dignity that they deserve. And you saw the video from my really dear friend right across the hall from me. He's a Republican, by the way. That wasn't important to mention in his video, but we have collaborated on so much together, and we're both hoping that we can get this legislation signed into law. We're preparing to reintroduce it very soon, and I want you all to stay connected with us. We will see you again, hopefully a year from now or a little bit more. Continuing to make this an annual event is critical because we want to make sure that we can bring people all the latest news and information, and we also know that there will be people that we need to wrap our arms around between now and when we gather again. I want you to stay connected with my team and with me, so you can sign up for updates at my website, wassermanschultz.house.gov. You can send your questions or feedback or criticism or praise, anything you want, by texting me directly at 954-866-9444. And finally, as we all know, cancer is relentless, and so we have to be just as relentless in our fight. For early detection, for equitable care, for a survivorship journey that is navigable for every patient, and that we don't forget about people who are right at the precipice of a cliff. Once they're done with their active treatment, we want to make sure that they don't topple off the edge and have so many other complications and concerns and issues arise as a result of not understanding how they can navigate that journey. I'm so grateful for everyone's knowledge and passion and their presence here today. It is only by joining forces that we can create a lifeline strong enough for every cancer survivor and the community that surrounds them. And I look forward to seeing you all again at the next summit. Before we close the plenary speaking session, one final reminder about our workshops, which are going to begin just across the way as we wrap up. There will be 3 different workshops, one on financial toxicity, one on wellness, and one on connections, running 2 sessions each. And you can sign up at the registration table just outside the theater on your way out if you haven't already. There's limited space, so don't miss out. Thank you all so much, and we'll see you next year.